Hello, check 1 2. Check 1 2. Check 1 2. Hello, check.
A very good morning to all. We joined together for the Meet the Expert over coffee. So we are waiting for the coffee. Meanwhile, let me introduce you to today's experts. Our topic is radiation-induced liver injury after SBRT, prediction, prevention, and future treatment plan. We have experts, Dr. Chandan Guha, Professor and Vice Chair, Department of Radiation Oncology, Einstein and Montefiore Medical Center, USA. Our second expert is Dr. Reena Engineer. She's a professor, radiation oncologist, and gastrointestinal DMG at Tata Memorial Hospital. May I please request our experts to join us on stage. We have our lead discussant today, Dr. Deepti Sharma, who is Consultant Department of Radiation Oncologist, Institute of Liver and Biliary Sciences, New Delhi. And our panelist, Dr. Manoj Kumar from ILBS, New Delhi.
Twice with the radiation-induced liver injury. So what is actually, what do you think the clinical manifestation of radiation-induced liver injury?
No, she's asking.
You first. So, traditionally, classically, radiation-induced liver disease historically was for Hodgkin's and lymphomas. So those were liver which were normal livers. And the classic story was anictoric without bilirubin high, anictoric ascites. Intractable ascites which will kill the patient eventually because liver will fail. So that was how it was discovered. Then RTOG had a famous trial where they did, those were the days of hyperfractionation being, you know, I mean, these are history which most of us don't remember anymore, but Marvin Rotman, who does GYN, you know, those days, did a trial for RTOG where it was chemotherapy, idoxyuridine, and radiation was given. And it was unfortunate because several patients, this is the RTOG trial, so it's a cooperative group, several patients developed radiation-induced liver disease, and this was fatal. So the trial was stopped. So we did manage to do harm more than any good. So then there was a whole time where nobody wanted to give radiation anymore to the liver until in 2000, University of Michigan, and this is Dr. Ted Lawrence, who started again idoxyuridine with hyperfrac. Those days there was a lot of excitement about break the dose into 2 doses and give 6 hours apart, and they did by 2 fractions. And again, now they started calculating what is known as normal tissue complication probability. The only problem is it's a probability. And yeah, it's a model. So you can't predict what your particular patient, where they will fall. But still, at least radiation-induced liver disease got started. And in radiation, as you know, we all face it, that once patient gets radiation, then after that, whatever happens, somehow we tend to blame radiation at that point. So overall, the whole idea was, can I treat without causing this ascites and liver failure? Yes. Okay? So the net result is we never did, like medical oncology, a trial where you dose escalate to find the toxicity and then come down. Because radiation, you are not supposed to cause any harm. Okay? So all the NTCP models showed one thing very amazing, that if patients do get this ascites, etc., maybe 3 weeks to 6 weeks after radiation, that is the delayed effects, etc. Now, in a traditional, right now in the liver cancer, as you know, the patient already have liver function abnormality. Deranged. And so the ILBS score or whatever you were looking, we start observing that you don't need to have ascites, but the ILBS scores keeps on dropping after radiation. So the latest, whatever will happen, have to consider, is liver function normal or liver function abnormal, pre-existing, and then you continue.
And also this post-radiation, whatever we see, the RI-LD is typically happens in majority of the patients, and it is temporary. Like it drops down to 2 points max, and then like when we see after the liver starts recovering after 3rd week. So we do explain the patient, counsel the patients, and the M.I.C.E people also know that this is going to happen, and in our hospital they manage. So most of the patients, and also we have to take care that what were the RT scores, and what was the liver function pre-RT, and then we have to not only reduce our doses, if there's, we have to also think of giving the volume of liver, as long as we meet the median dose. But sometimes, sir, I keep thinking the median dose like 15 gray, but these cases I tend to just keep the margin at 12 gray, because when these scores are bad pre-radiation. So we have to be extra cautious, and this is what we do. I don't know what you do in practical.
No, it is. You were right. So, as you know, in the original paper, if 1/3 of the liver was covered only, you can go as high as 80 gray, because once you are dead, you are dead, the liver tissue. So, liver being a parallel structure, it's not a serial structure, you have ability to do real ablative radiation, if possible. So you were right that you were making this complication, normal tissue complication probability model, and based on that you were selecting doses. And that's okay, because now you have the RTOG trial coming out and other trials which are phase 2 trials. But still, it gives you the guideline of where to choose, and so that's perfect.
So, sir, actually, in the patients with CLD, it is not mainly the classical RILD, it is mainly the non-classical RILD which usually manifest, and which is characterized by increase in transaminitis more than 5 times of the normal. Generally, there is increase in bilirubin, decrease in albumin, increase in CP score by more than equal to 2 points. So, what we have seen in such group of patients, routinely patients has increase in transaminitis is there, and which in due time, in about 4 weeks time, it settles down also. And that is the thing. So there's a new thing like biliary tract injury also, which is also included in RILD right now.
So as a clinician hepatologist, I would like to know, is there any threshold of liver function test beyond which you would not consider radiation in any patient?
Well, so if you look at all the randomized trial you guys are doing for, immunotherapy and stuff, Child-Pugh B and C, patients who actually need more treatment gets less treatment. So that's not the paradigm which we would love. Only in liver, the larger the lesion, the lower the dose, which obviously, as you know, would not be adequate. So obviously, we still need something for poor liver function. But then you also need something for poor liver function with or without cancer. So leaving that aside, there is this comment which I would like to make. So imagine in a cirrhotic liver, there is liver which is proliferating. No wonder if you give radiation, those cells will die. And if they die, transamine will go up. That's one. Second thing, there is a phenomena which you know very well called acute phase response, which is basically a cytokine response. And albumin happens to be a negative acute phase protein, which means that when IL-6 and TNF-alpha goes up, albumin goes down. So even if you don't do anything, meaning just radiate one part of the liver, because IL-6 has gone up, albumin will go down. And that's why you need to also see like alpha-1 antitrypsin or some other plasma protein as a marker to really feel that this albumin low, is it poor liver function or is it acute phase response? Okay? So you need, like bleeding or factor 8, etc. So,
sir, yes, what we have seen in our practice, that after the first radiation, patient generally develop fever. And that fever is not mainly because of the cholangitis, it is because of the acute phase reaction, release of interleukins. And what we have seen that after, if there is any single episode of fever after the first fraction of radiation, those patients generally tends to do good in long future.
Because it's a response to the body, immune response.
Yeah. So, what are the prognostic and predictive factors for radiation-induced liver injury? Means what factors we should see before taking the patient for radiation therapy?
So, like, sir, exactly, I'm not very clear about the threshold, but yes, we do get, so none of the patients we receive have absolutely fine liver function tests. So they do have deranged. So as he asked, so is there any cutoff of albumin you say that we will not, like generally below 2 or below 2.5, we will not radiate at all?
okay. So as you know that even for the eligibility criteria of these trials, using CP score is really ancient.
Yeah. It's
Okay. Throughout hepatology, you are not using Child-Pugh to describe.
black coffee.
So we should really try to refocus whether it's albumin or sodium in LB score or whatever
MELD
score you are using in
Yeah,
your
yeah.
MELD score,
Yeah, MELD.
whatever
MELD
you are using, I think within India, because again, as you know that for normal tissue injury, there is a cultural and genetic makeup which is very, very critical, right? What is happening in the Caucasian population, you should rediscover what is happening in here with the curcumin you have in the diet, everything else. Probably here you now have metabolic liver disease as a very high risk. So you cannot equate hepatitis B from East Asia with the diet-based here, right? So my suggestion is that within your big series, both ILBS and Tata has a huge series, do convert all what you have done into whatever you do, whether it's MELD sodium or ILB score. I like ILB, you know.
Me
so,
too.
yeah, so just do that and see which patients are having deterioration of liver function. You know, that brings a very critical point that in hepatology, a global liver function, this ILB score, etc., are global liver function tests. And we still have a big elephant in the room where do we know spatially liver function, because for radiation oncologists, where are you giving the dose and what function of the liver is there is important. Because if the volume you are radiating is not functional, so who cares? Give as much dose as you want because they won't be contributing to the whole. Is the low dose, which is going to normal liver, quote unquote, which is actually abnormal, is what you would like to know.
Yes.
Yeah, true. That is why protons are coming up, you know, that they have lesser damage and lesser ILD because low dose pill is lesser in the protons.
Yes.
Yeah.
Sir. So generally we used to go for the LB score. Child says like it is the part and parcel. So generally up to B7 with LB score. What we have found in our patient group of patients, like dividing LB into grade 1, 2 and 3. So there is a cutoff of minus 2.2 if as per the ROC curves. So if the LB score is less than minus 2.2, then those patients of LB2 also do better as compared to cutoff of more than minus 2.2.
Okay.
So that is the thing that we have seen in our group of patients, because the patients with LB score towards 3, grade 3, they tends to behave like 3 only. So in the long term, the overall survival is also not good, and sometimes we need to lower the doses. And in few patients, we are also doing ICG 15, ICG 15 retention at 15 minutes to find out the baseline liver function test. Further, then we can easily find out how much dose we can just push to the tumor and how much the mean liver dose can be attained in such group of patients.
I was reading some material about this role of SPECT to see the rest of
Functional
the liver,
liver
the functional,
imaging.
yeah. So do you do that in your practice?
No, but you should, I mean, we do just DCE MRI,
Okay.
which
Yeah.
is
MRI.
kind of
That's
sinusoidal obstruction syndrome
Yeah.
you can look at. But I'm looking at your thing. When you discuss the adaptive, we can talk about this. So I'm holding it back
okay.
until the adaptive. But to mention to our hepatologist colleagues, what about HepQuant studies or other type of measures? Because in ICG clearance, intentionally, ICG is not metabolized, mean enterohepatic circulation does not affect. But are there any bile salt-based tests like HepQuant or others, which radiation oncologists, what can we learn from your general liver function test, which radiation oncology, remember that unlike medicine, maybe spatial function doesn't matter. Maybe global function is enough. But for us, we really would like a spatial liver function, and the SPECT-CT and others are for spatial liver function. What do you think?
In clinical practice, we generally do not use these tests, but functional liver tests like ICG retention test or aminopyrin test, but these tests are not easily available except ICG 15. So that is the problem. Otherwise, if these tests are routinely available, then functional liver tests are, maybe they can give more predictive value for radiation-induced liver injuries, but not available actually.
So what should be the pre-treatment viral load? Means suppose a patient is having acute hepatitis just diagnosed with hepatitis B infection along with the HCC. So in such group of patients, how you go with?
Yeah, you definitely treat the virus first, because invariably, this is very well studied. Radiation was there in the primordial evolution, in the earth. there are so many virus promoters which are induced by radiation directly. So hepatitis B, HIV, herpes virus, you can turn them on replication just by radiation. What do you mean by that? Mean radiation-induced free radicals and NF-kappa B are there in the promoters of this virus. So for example, HIV will go up, hepatitis B will go up.
Acute inflammatory response.
Yeah, exactly.
Yeah, that has to settle.
So unless you, if you don't do anything, your transaminitis will go sky high.
Yeah.
So you need to treat antivirus, whatever.
At least for 4 to 6 weeks. That's what it is.
And then you can start.
Yeah.
Thank you, sir. So now the concept of functional liver images, as we are already discussing, with the functional liver images, we can go to find out which part of the liver is doing better, and we can reduce our doses to that part. So it's mainly the SPECT and MRI that you have already. So now the concept is adaptive SBRT. So what is your experience of adaptive SBRT with the use of ICG-15?
Yeah, so what I was explaining before we started, that University of Michigan has, so when do you do adaptive SBRT? Not for patients who doesn't need it. I mean, they will be, the volume is 3 centimeter or less, no problem for standard SBRT. It's that group of patients, like the B7s, or the larger lesions, like
more than 10 centimeter. Because in India we get the reference of 10 to 15 centimeter usually.
Well, I mean, 10 to 15 is really big, right? But even if it is 5 centimeter and above, and within your database, that's why I'm encouraging you to convert your database into liver function test. And there's no other place than ILBS and Tata who can do that. If you pull your data together and see the ones where the liver function deteriorates over time and doesn't go back to normal, okay? These are the group of patients who should get adaptive SBRT. Now, couple of things which has come up so that you know the history of what adaptive SBRT means. That larger the fraction size, the biology is very different than the fractionated radiation we give in the clinic. So Ted Lawrence and their group in University of Michigan have developed a test where you give, instead of 5 fractions, just 3 fractions over a week, Monday, Wednesday, Friday, and then wait about 4 weeks.
In how much dose?
Whatever you have calculated as your NTCP model.
So it should be planned for 5 fractions and you deliver only 3 fractions.
So let's say 8 gray times 5, let's say is your dose. So you give 8 gray, 8 gray, 8 gray, 3 doses.
And then wait.
And then 3 weeks to 4 weeks later, do your scan. And if there is no deterioration of liver function, continue with the 2 additional doses. If there is deterioration...
You do the ICG scan?
They did ICG, but you can do, I mean, you can take your favorite scan, like if it is MR, it's MR.
Okay.
But if there is deterioration of liver function, then you decide, instead of 8 gray, make it 5 gray, the 2 additional doses. Or, so in their study, 50% or 55% was able to make the whole 5 fractions.
Okay.
Then 25%, they had a reduction, and 25% don't give any dose, don't do any harm.
Yeah.
Okay, so that's one thing. Then there is another concept which is evolving very much, which is called pulsar. This is coming out of Bob Timmerman and the group in UT Southwestern Dallas. And the idea is, why are you doing radiation? If the patient's liver function is poor, if there is field cancerization defect, and for example, I have been working with carbon ion, and carbon ion happens to be one of the best treatment for hepatocellular carcinoma, okay? Because again, liver is a parallel structure. So if you can give high dose, etc. So the problem is, despite carbon ion, there is a recurrence, which is the second malignancy which comes in. So in liver function, we not only have to keep the liver function intact or regenerate the liver, but at the same time prevent a recurrence, not just from the local control, but from future. So what Timmerman has proposed is that weekly or monthly single fraction SBRT, like you do for cycles of chemotherapy, is it possible to do cycles of SBRT with immunotherapy?
Okay.
Okay, so if we do a immune checkpoint has its own toxicity, radiation has its own toxicity. So why, who gave you, the story of fractionation came from radiating ram testis. It didn't come from treating tumor. So can we go back and have a model where periodic cycles of SBRT plus immune checkpoint can be given, because that's what will be needed for the patient. So these are the two reasons of adaptive design, and obviously having spatial or global liver function, and Dr. Sarin may comment, I was talking about the HepQuant and other enterohepatic biomarkers. It might be good for you to design a trial which will allow you to combine adaptive design with immune checkpoints and continue.
So what we have seen in our few of our patients, that after giving radiation therapy with a full dose followed by immune checkpoint inhibitor, few of the patient decompensates also. So means we are just on the back foot, means whether to give or not. Means what should be the actual gap in between giving radiation therapy followed by immune checkpoint inhibitors with ati-bev, or do you prefer nivolumab for the same?
No, it's a fantastic question, and I hope to answer some of it during our talk later. But the question you were asking is, what is the role of, so one of the questions you have to ask whenever you do combination therapy, is radiation helping to amplify the immune response and get a better response for immune checkpoint? Or is immune checkpoint helping a poor radiation dose be better? Okay, so these are both possible.
Both possible.
So in my case, what I would suggest is that the whole purpose of radiation, if they are to amplify immune response, is to give a primary immune response, and only when you get exhausted T cells, then add the immune checkpoint. So even if you wait 3 to 4 weeks, it's perfect, because I will show you data that it's almost around 4 weeks that the exhausted T cell starts coming. So there's no point putting immune checkpoint, right away. And in fact, some of the trials, you will see those who have done concurrent radiation and immune checkpoint, they did not do
inferior outcomes.
Inferior outcomes, exactly.
So
yeah,
it should be
that's
like,
why sequencing matters,
Yeah.
and now more and more they're saying, if possible, start with SBRT and then add into your ICIs. And what about TKI, the interaction with TKI? So in India, we'll end up giving most of the time TKI because of affordability. So then how do you sequence the TKIs?
So the impact of TKI, and as long as the toxicity profiles are not there, so the whole idea is, if there is cell death, there is antigen presentation, there is any evidence of immunization, then only exhausted T cell comes into play.
Okay.
So you have two choices. One is what is called sandwich, where you start with 1 or 2 cycles of immune checkpoint and then bring in the TKI or radiation to see, the impact, but not concurrent.
Okay. Yeah.
we are
Okay.
also not doing
Yeah,
concurrent
no.
TKI with radiation, because it leads to increase in toxicity.
You just don't know.
Yeah.
Yeah.
So I think the last is advanced radiation therapy technique, and you have already discussed about that. So I think it's time to close the session
Yes,
for
please.
the next session.
Yeah.
Thank you so much,
Thank
sir.
you so
Thank you
much.
so much, ma'am. Thank you so much.
for doing this.
Thank you, the expert discussants and the panelists. Thank you so much. Now we move on to our next session, that is compensated cirrhosis with SCC, with PVTT presenting with recurrent variceal bleed, how to go. We have lead discussant Dr. Chandan KN, Senior Consultant Hepatologist and Lead Liver Transplant Physician, Department of Hepatology and Liver Transplant, Gleneagles Global Hospitals, Hyderabad. We have Dr. Manoj Sharma, Professor and Head Department of Hepatology, ILBS. And today's expert, Dr. Shivkumar Sareen, Director, ILBS. May I please request Dr. Chandan to join us on stage? And
Good morning, sir. At the outset, first, I want to thank my teacher, my mentor, Professor Sareen, sir, for this opportunity. Today, we are going to talk about compensated cirrhosis with HCC and variceal bleed. This is especially important because variceal bleed is one of the most favorite topics of sir. So there's a lot to learn from him today. So this is a case of a 56-year-old gentleman, a teetotaler, diabetic on treatment with no contributory family history, with progressive weight loss of 8 kgs since 3 months and dull right upper quadrant abdominal discomfort since 1 month. On evaluation found to have multifocal HCC with right portal vein thrombosis and enlarged para-aortic lymph nodes on a background of cirrhosis. Etiology was HCV related. Genotype 3, log 7 RNA. So this is a CT. We can see in the left side arterial phase the arterialization of the right portal vein and this diffuse arterial enhancement in segment 6-7 in the background of cirrhosis. And in the right picture is venous phase with complete washout, and of course the portal vein thrombosis extending up to the main portal vein, but main portal vein is patent with large splenomegaly and all that. Endoscopy showed large varices, small GOV2 and mild PHG. Primary EVL was done. He was started on antivirals, soft Dacla and ribavirin, and also non-selective beta blockers was started. So diagnosis, portal hypertension, large varices, small GOV2, primary EVL was done, HCV related cirrhosis, genotype 3, log 7 RNA, started on antivirals, compensated, multifocal HCC with right portal vein tumor thrombosis, AFP 267, PEVCA 7800, BCLC stage C, performance status 0, ALB score grade 1. So next option, I'd like to ask the panelist, should we try SBRT followed by transplant? Should we try palliative TACE? Should we try immunotherapy or just only oral chemotherapy?
I think in today's era, a combination would be a better option. For example, SBRT followed by immunotherapy, or if you are considering TACE, then TACE followed by immunotherapy. So rather than any one answer, combination would be a better choice.
Yeah, I think this patient probably will benefit with SBRT and followed by either transplant, which I doubt because lymph node is present. Am I right?
Yes, sir. Locally advanced.
Yes. Yeah, so I would doubt if transplant would be possible. But if it is possible, it will be a good choice. If not, SBRT followed by immunotherapy should be a good choice.
SBRT followed by immunotherapy, sir?
Yeah, that would be my choice.
But before that, varices...
Yeah, you didn't ask that question. Next option. Well, I was wondering why EVL was done for primary prophylaxis.
Sir, he has portal vein thrombosis, and that's why primary EVL was done. So that at least later in time, after suppose varices eradication is obtained, then we can attempt immunotherapy. Keeping that in mind, I think it was done.
Yeah. So that is the key question, I think, which we should debate is whether such a patient who has large varices and has PVT, what is the success rate of EVL?
EVL, yes, sir.
And in such patients, EVL is good, but the rebleed is going to be high.
Yes, sir.
And I would have done beta blockers.
We kept him on a combination of beta blocker with EVL, sir.
Yeah.
But only
if
for
you have done it, it is fairly good because beta blocker is the keystone for these patients for prevention of development of HCC, progression of HCC, decompensation on therapy, and preventing first bleed. All that, I think beta blocker is the keystone for HCC with cirrhosis and PVT. So.
And before starting bevacizumab, you must eradicate the varices.
Yes. That was one of the main reasons we did. It was EVL was done, I think. Because other options, curative options were limited. Like sir said, transplant. There's already locally advanced disease, and TACE also unlikely to help in this patient because of the large lymph nodes.
But I'm not sure whether you need bevacizumab before bevacizumab eradication of varices. I think Dr. Manoj says, do you have any guidelines which suggest?
Increase in antivascular endothelial growth factor will cause incidence of bleeding high if we start bevacizumab without eradication of the varices.
But at least small varices.
Small varices should be there.
Yeah, I think giving beta blockers is as
because
good.
Main trunk of the portal vein is involved.
Yeah. I would still give beta blockers in these patients and be hesitant to do a EVL in these patients. There is a recent paper, I am sure you must have read, by Dominique Thabut in hepatology, where it is clearly mentioned that we give beta blockers, only do banding if the patient has bled. Not if he has not bled, just give, this is I think August or so, and JHEP reports also. Manjul, you have any idea? What should we do?
I did not read that paper, sir. But
you all follow doing beta blockers, you all follow EVL before giving it? No, you give EVL before giving bevacizumab? Now he has bled?
So that's no, I didn't give immunotherapy, so but he bled.
Oh, he bled?
He will bleed.
He's a bleeder.
So there's only trailers and no main course.
Okay, come quick.
So this is the HCC, BCLC. So our patient is a BCLC stage C. As per the guidelines, we should give first line is immunotherapy. Otherwise, we can go for the oral chemotherapy. So he was continued on antivirals and beta blocker, and because he did not have, he still had large varices and just recent EVL was done, and he was not started on immunotherapy. One more question, sir, pertaining to this. With a patient with high viral load, is still immunotherapy possible, or I mean, not just a conceptual question I wanted to ask.
Yeah, generally one should, at least for hepatitis B, 2-log DNA should come down.
Yes.
But sometimes the tumor is quite aggressive and you can take chances by giving a dual antiviral, but this is not in guideline. And also by antiviral for hep C you can start, because in 10 days time the virus comes down.
Yes, sir.
But preferably if you have time, you should try to bring it down at least 2 logs or so.
So that's why you started on lenvatinib, because of high viral load and also large varices.
Yes.
And no other treatment options were available. After 2 weeks, he came to emergency with 3 episodes of hematemesis. In a ER, heart rate was 119 per minute, BP 98/47, conscious but anxious, pallor, lactate was 6.7, hemoglobin 4.3 on BBG. So this is, I think, one of the papers that everybody should read. Sir's initial paper in 2011. Till date, this is the only paper which gives all the definitions of bleed. And there is no other paper which we can find in literature which is so descriptive. So this, as per the American College criteria for amount of blood loss, our patient was in class 3 with borderline hemodynamics, tachycardia, and anxious state and loss of blood loss. So as per the APASL guidelines, fluid restriction started immediately. Door to needle time was 20 minutes. He shifted to the liver ICU, central line secured, blood transfusion started, broad spectrum antibiotics, PPI infusion. Bedside endoscopy showed post-AVL ulcers with active ooze and stomach full of blood. So this is the treatment guidelines as per the APASL definition. Terlipressin should be the first choice in these patients after baseline ECG and continue bolus every 4 hours. Now coming to the options to the panel, should we do EVL, should we do glue, should we do SEMS placement, emergency TIPS or TIPS plus BRTO?
SEMS placement, post-EVL ulcer bleed.
Any other suggestions?
How much was the blood loss? Was it massive bleed?
It was massive. So hemoglobin was 4.3 at
4.3.
Yes, lactate 6.7.
If possible, TIPS should also be considered, because active bleeding with child B, patient is child B cirrhosis at least. He is more likely to bleed in the next few days.
Yes, sir.
Yeah. I agree with Avinash and Dr. Manoj that SEMS placement with potential assessment for TIPS should be done. That should be there.
So, okay. Not the endoscopic options, sir.
It's an EVL ulcer bleed.
Yes.
You can do an emergency endoscopy to try and control the bleed, but it will continue to bleed
yes,
because the tumor must have invaded also the left gastric, and because of that it will probably not settle down and we can create more problems.
So in that instance, will TIPS help, sir, this patient?
I would not do TIPS as the first option. I would do EVL. I will do the terlipressin infusion,
Yes, sir.
and I would wait for maybe few hours. If it settles, it's okay. If it doesn't, I would do a Danisella stent placement because it is expensive and many patients cannot get it.
Yes, sir.
And if that also doesn't help, then emergency TIPS. But one attempt more because it's an esophageal variceal bleed,
sir.
and I will not do glue in esophageal varix.
That's good. Yes, sir.
Yeah, you're right, if he's bleeding from gastric varix, then glue for gastric varix.
So this is a Korean paper I found for EVL ulcer risk factors and on-site rescue treatments. So out of the series of 457 patients, 47 patients had EVL failure, and on multivariate analysis, male patients, hypovolemic shock, active bleeding on endoscopy, and history of previous EVL were independent risk factors for EVL failure. Using glue was the common treatment they had given, on-site rescue treatment followed by SB tube and EVL retrial. So, but Babino 7 consensus is not pertinent to this patient. Generally, as for refractory variceal bleed, TIPS is recommended. If refractory variceal bleed, this balloon tamponade with or self-expanding metal stents as a bridge therapy followed by TIPS is more salvageable. And this is again the APSL guidelines where they say the risk of rebleeding is more in those with portal vein thrombosis and especially with HCC, and even the severity of bleed is more with portal vein thrombosis. But sir, keeping this patient's advanced prognosis in mind and the tumor thrombus extending into the portal vein, the right portal vein completely thrombosed, extending to the main portal vein, and suppose if we still control the bleed with EVL and terlipressin infusion, and of course, then what are the treatment options after that for the tumor thrombus? And
yeah, he came for his tumor.
Yes,
and we converted into a bleeder.
Yes. After he recovers from this, sir.
Yeah, so I think we need to be very careful now. The normal person, if he had not bled, his median survival would have been 38 months.
Yes.
After his bleed, his median survival is now 5 months. So if he is surviving 5 months instead of 38 months, what therapies can you give him? I would seriously consider controlling the bleed, and if he has not decompensated, and Avinash has that beautiful work of ischemic hepatitis, if he has not developed ischemic hepatitis, if he has not decompensated, I would stabilize him and just put him on lenvatinib. I would not probably give him SBRT or immune checkpoint inhibitors because he will not be a good candidate now. Monotherapy with atezolizumab is not adequate. Nivolumab can be tried, but it would be now difficult to treat him.
But suppose if we control the bleed with SEMS placement, sir,
yeah,
and in the follow-up can still be considered for SBRT, because portal vein thrombus is the one in the table which we saw.
yeah.
Is
So
risk of rebleed and severity of bleed.
there is enough data that SBRT, TACE, TARE all increase the pressures.
Okay.
So his pressure, the portal pressure will again increase and he will rebleed.
Rebleed, yes.
So unless, yeah, if you do TIPS, which is not a bad idea, if you do TIPS, it does not cause progression and the tumor does not worsen, but TIPS can cause decompensation, yes, per se, because whole of the right lobe is gone.
Yes, yes. That's
So I would not try and be heroic in treating the drug. I will simply give lenvatinib or sorafenib for him, not do anything more. Because he has bled, so we have converted a potential therapy now into just stabilization therapy.
Yes. Thank you, sir.
Well, few more things in this patient. Can you go back?
Yes, sir.
What was the platelet count?
I didn't show that, sir. It was around.
Yeah, I thought I missed it. Independent markers. So if the platelet count was less than 100,000,
75,000. That's right.
So I would never do EVL in this patient. In such a patient with a platelet of 75,000, I will just give beta blocker, and there is enough data to say despite large tumor, if you do fibroscan and liver stiffness is more than 16, there is adequate portal hypertension. Don't have to wait for 25. More than 16 LSM is enough. So.
But he basically came with high risk varices, sir, and
I know.
And he was referred for clearance for immunotherapy by oncologist.
Yeah.
We said first we had to do varicose eradication, and otherwise,
no.
patient, yeah.
I think it's a mistake.
Yeah.
It is a mistake. We don't have to eradicate varices.
Yes.
The risk of bleeding on bevacizumab, atezolizumab in EMBRAVE was 14%, and risk of post EVL ulcer bleed after this will be 50%. So risk is 1 in 10 versus 5 in 10 post EVL ulcer bleed in these patients. So it would not be a good idea.
So basically he came to us because for transplant was possible. We said no, that's out of question.
Yeah.
Then I said at least we can give antivirals and treat the portal hypertension, and then.
Now what you did was right. You actually gave beta blockers. If he was adequately beta blocked and his heart rate had 55, 60, then I would say don't worry about bevacizumab causing a bleed. I would go ahead and give the drug.
Yes.
I would not touch him with a pole and do a EVL.
But his main portal vein was patent, sir. Only extending to the right portal vein has gone.
Yeah.
Extension was there, but it was.
You can see the main
Yes, sir.
portal
It's
is
there,
also affected in this.
In the right side picture, sir, that is the large lymph nodal mass. I didn't see. This is the portal vein which is patent, sir. The main portal vein. Yes, sir.
And okay. Okay. Well, so you all do routinely EVL in these patients? No? Manjul?
Maybe if patient is a non-bleeder, then beta blockers will be sufficient.
Non-bleeder,
He's a
no?
non-bleeder now.
He is a
You
non-bleeder.
are initially
Okay.
non-bleeder.
Primary EVL was done, sir.
Yeah.
And then
Non-bleeder.
patient bled and became a bleeder.
Yes.
Yeah.
So we
But
should
that's-
not do primary EVL actually.
Any comments from experts? Indonesia, Rinaldi, what would you do in this?
Yes. Yeah. Thank you, Mr. Alin. Yeah, I think in this kind of case, especially this case is HCC, and I noticed only with the right portal vein thrombosis. So, in my own experience, I think it's almost similar. Yeah. I mean, first time that in this country, because in Indonesia, there's not so many development yet in the SBRT. So in this kind of state of disease, usually we offer the patient directly to the immunotherapy, but immunotherapy is not covered by the government. So in the setting of the maybe let's say like private insurance coverage, so we offer immunotherapy, but unless it's not that we.
Will you do banding or no banding?
Oh, for the varicella, for the
Yeah,
varicella
for primary
bleeding.
prophylaxis
Primary
of a
prophylaxis.
PVT in a cirrhosis.
If no bleeding, no bending, especially if low platelet count, very low. But if there's a bleeding in the, especially in the like from GOV or the isolated fundal varices, in this kind of case, we use the EUS for evaluation for the deep vascular, the presence of the deep vascular. And then we try to inject the cyanoacrylate inside them, but not for the esophageal varices. So before the immunotherapy or the oral systemic treatment for this patient.
So Chandan, what is your experience? What do you do routinely?
We just give oral chemo, sir, for these such patients, and don't give them immunotherapy. One of them is the.
So you mean all those who require immunotherapy but have large varices, you don't give?
No, sir. Those who have large varices, we give beta blocker, but we still the risk of bleed is reported with immunotherapy. So we prefer the varices eradication or at least small varices before we consider the immunotherapy.
See, I would be more hesitant if a patient has large varices with high risk sign and he goes for TACE.
Yes, sir.
Or SBRT, his intrahepatic pressures will increase more. He will bleed more. So I am not so bothered about bevacizumab causing bleed. I haven't seen, we must have more than 70, 75 patients, but never. So I think it is overrated that bevacizumab causes variceal bleed or can precipitate a bleed. No.
Even with those with high risk features?
Yeah, even with high risk. So if you have given adequate beta blockade, I think you can manage. They are difficult patients.
So beta blocker, antivirals, and we could
Yes,
have started
yes.
bevacizumab.
Yeah, I think that should be good
Maybe
enough.
At least after 1 month of antivirals.
The only disadvantage of beta blocker is there is already compromised blood flow.
Yes, sir.
So you have a portal vein thrombus, so the blood flow is already low. Now you're giving beta blockers, so it will further reduce the blood flow, possibly, and it doesn't decrease the arterial. So if you give carvedilol instead of propranolol, it is a better drug. In fact, that is the recommended drug.
Yes.
So give carvedilol and do adequate beta blockade. Then I think TACE, TARE, SBRT,
Combination pyramid.
all therapies should be after giving adequate carvedilol. Any other comments from? No? Yeah, please.
That was a very enlightening discussion. So what do you do for those patients who actually don't respond to beta blockers with the decrease in heart rate?
Who bleed?
No.
Who do not respond?
Yeah, to beta blockers.
Yeah. I would give ivabradine. I would bring down the heart rate. It is not important to bring the portal pressure, it is important to bring the heart rate down. So all non-responders go on to ivabred and decrease the heart rate to 55.
Sir, we have a data of, as you correctly mentioned, 65 patients who have received atezolizumab and bevacizumab. Only 3 has bled. So 3 out of 65, and those who had high risk of bleeding and a high child C score with around 11 or 12 and high MELD. So those were already at high risk of bleeding. So it was not ascertained that bevacizumab might have caused the bleed.
Dr. Satyendra has collected all the data. So we have 65 cases treated with combo, and 3 have bled, and these 3 bled without EVL or with EVL?
Sir, without EVL, sir.
Without EVL. And they would have otherwise also bled?
They had high MELD score and high child score.
High MELD and high child score. So they had bled spontaneously. And do you know how many bevacizumab or ETA combination, how many courses were given?
Sir, they were different patients, but mean doses were around 5 doses, sir. All those 65 have not completed 6 doses, but around mean doses were 4 to 5, sir.
Yeah, so I don't recollect patients having bled on the combo therapy. They would have bled otherwise because they were high risk varices, but not otherwise on this. So,
yes, sir.
Is that all? So this patient, what happened? Is he alive or dead?
No, he's alive.
He's alive? So what are you going to do with him?
So he's on oral chemo, antivirals and beta blocker at present.
All right. All the best. All the best for your patient and for you.
Thank you,
All
sir.
right. Yeah, thank you.
Thank you, sir. So for the next session, I'd like to invite Dr. Cosmas Rinaldi. He is Associate Professor in Medicine and Senior Consultant, Gastroenterology and Hepatology Intervention Endoscopist, Septomedical Faculty, University of Indonesia, Jakarta. Further, as a lead discussant, I'd like to invite Dr. Sahaj Rati. He is Assistant Professor, Department of Hepatology, Postgraduate Institute of Medical Education and Research, Chandigarh. And as a panelist, I'd like to invite Dr. Prahlad. He is Consultant, Department of Gastroenterology and Hepatology, Kalinga Institute of Medical Sciences, Bhubaneswar, and Dr. Junaid Ahmed Khan, Consultant Cardiovascular Surgeon, Assistant Professor, Cardiac Surgery, Lucknow. Hello, sir. Please.
X-rays our failure.
स्क्रीन चालू करो यार.
Slides नहीं है.
Sorry for the inconvenience.
In any case, I do not have slides because this is such an evolving topic. I thought that we'll have more of an informal discussion regarding this because the data is rather limited, predominantly. So endohepatology has been, in the last 8 or 10 years, there has been fascinating evolution of this kind of subspecialty. 2012 was the first time that the term endohepatology was used. I believe in the last 10 years, the indications have expanded rapidly. Predominantly, I think where the value was added was when we started using EUS more and more for patients with liver disease. And we started realizing that gastric varices are very beautifully treated with EUS, and then we started doing liver biopsies. And that is kind of something that snowballed into a whole new field. And while right now it is pretty much in the realms of academic centers and research institutes, it is now permeating rapidly into clinical practice. And I believe the most fascinating or the most the spearheading procedures are gastric varices and liver biopsies. So just to get the ball rolling, Dr. Lismana, what are your thoughts on liver biopsy with AUS?
Yeah, thank you. Yeah, I think, you're right. Yeah, recently, I think because the EUS now have been used recently to evaluate the vascular problem related to the liver disease. So that's why people start to think that other than evaluate, let's say like for the presence of the varices, especially like deep esophageal varices, then with some cases that maybe would need liver biopsy to confirm the etiology, then we can do also correlate together with the evaluation for the presence of the varices. But I think in the clinical routine practice, still most people will do the percutaneous because a debate about this liver biopsy using the EUS. First, I think it's percutaneous is still a very simple procedure to do, even though that there was a paper that showing that comparing with the EUS guided liver biopsy and also the percutaneous liver biopsy. I think it's also that paper is come from India, and I think one senior doctor that to look at this comparison, and it showed that using the EUS that it's just like less pain for the patient, more comfortable, and then it can trajectory to many sites of the liver. But I think mainly in general practice, even in my own practice, I still do percutaneous liver biopsy because it's very simple, and also about the cost. Yeah, I mean, because we know that the FNA needle, even though now we can use the FNB, the core needle, to get a good sample, more sample, but I think the cost is still become a big issue, and then patient need to be sedated using anesthesia because of the procedure of the EUS. I don't know, maybe Dr. Manoj, yeah.
Are there any specific circumstances when you will consider US guided liver biopsy rather than percutaneous? Any specific instance you can?
At this moment, see, at present, I only perform the US guided liver biopsy when I think the patient also need another evaluation, such as like for evaluation for the gastric varices or other thing because of the bleeding, other thing, and also let's say like maybe patient with mild to moderate ascites, that if we cannot control the very good the ascites, sometimes using the EUS still can be used to do the liver biopsy. I mean from the stomach side, because it's closer to the liver.
And maybe morbidly obese patients.
Yeah, obese patient. Yeah.
So in our practice, we pretty much avoid using EUS for non-cirrhotic livers. Non-cirrhotic livers, we would prefer to do percutaneous. In cirrhotic livers, we are realizing more and more that usually we would otherwise go for transjugular, but we are realizing that EUS gives us a better tissue, and because we can visualize those small vessels so well, even patients who have a relatively lower platelet count, we've never had any patient who has bled after EUS liver biopsy. So, that is where I feel we are prospectively collecting that data, but I believe that EUS as a comparator to percutaneous liver biopsy will always lose, because percutaneous liver biopsy is simple, cheap, and very well tested. However, in cirrhotic livers, sometimes transjugular liver biopsy just does not give you enough sample. That is where EUS has the potential to shine, because the tissue that we get from EUS, while if we go by the gauge, it is slightly lesser than the 18 gauge, it is 19 gauge, but the length of the course pretty much make up for that. I completely agree that EUS liver biopsy right now has limited indications, but I believe that it is evolving. I see a lot of enthusiasm by many of my contemporaries, young EUSs who want to do EUS liver biopsies, but in my own practice, I use EUS only for patients who anyways need an endoscopy and may benefit from an liver biopsy because of cirrhosis. So the visualization of vasculature pretty much reduces the chances of bleed drastically. We have gone down to up to 40,000 platelets. We have done liver biopsies with no problems. And if ever we do see a Doppler tract, we can just press. EUS scope has heft. The transducer, the scope itself is a heavy scope. So if we try to compress the liver, we are able to compress it, and we can wait until the Doppler tract goes away. So there is that theoretical concern that these patients might bleed, but in our center, in the last 150 odd biopsies, we have not seen a single bleed. That said, I do not endorse using it in these circumstances, except for in protocol settings or research settings right now.
How does presence of ascites, whether mild, moderate, severe, affect your ability to do EUS?
No, so that's a very important issue, because if we have no ascites, even if there is a small bleed, it is tamponaded. But if we have ascites, even if there is a bleed, a cirrhotic liver cannot retract. It cannot cushion the blood tract. So for those reasons, I personally avoid in moderate massive ascites. There is no question. Moderate ascites also I usually avoid unless the gastrohepatic window is completely fluid free. So in those cases, we are sometimes okay with doing, but that is not optimal. That is a very case-by-case thing. It is not something that I can endorse on a scientific forum.
Yeah, I think for the US guided liver biopsy, I think still the The coagulopathy problem, I think, is still same with the percutaneous procedure. I mean, that's a limitation maybe comparing with the transjugular liver biopsy. I mean, if let's say like patient with the severe liver coagulopathy, I think maybe still much safer to the transjugular liver biopsy, even though I know it's also carries a risk because we have to pass the heart, the cardiac, but in patient with severe coagulopathy, because we know even like in US, even though it's the chance of the bleeding is very small, even we can use the Doppler and other things, but you know, and of course we know that in the patient with liver cirrhosis, sometimes the hemostasis profile is not always accurate, I mean, to show the condition. But I think in patients, let's say, with severe or prolonged INR that's difficult to control, I think maybe transjugular liver biopsy is still more safer. I don't know, Dr. Manoj?
We are not doing US-guided biopsies. Maybe recently we are doing a trial on percutaneous versus US-guided. Dr. Vikram is doing that, but in routine clinical practice we do not do. And the next important thing is US-guided gastric varices, detecting gastric varices. That is a much more important area rather than US-guided liver biopsy. So how do you tackle gastric varices in your clinical practice?
Yeah, I think it's also a challenge condition, because we know that until now still no very fixed guideline. And when we found that there's like incidentally finding like gastric varices, let's say like no sign of bleeding, no bleeding spots, and then whether it's small or large, and then whether we have to evaluate whether I mean, there's a large, deep gastric varices that we could not see through the luminal endoscopy. So I think still debatable there how we have to use the EUS routinely in the daily practice when we found the gastric varices or isolated gastric varices. But in our clinical practice, usually we still do just the standard, I mean routinely standard endoscopic evaluation and treatment, let's say for large gastric varices. Still most doctor, they still do the standard cyanoacrylate injection with the needle only luminal. But in our experience that some patients they still rebleed, yeah, I mean even after the cyanoacrylate injection. So now we try to change that, especially in the patient with large gastric varices, or maybe patient with not large gastric varices but still rebleed after the injection. Then sometimes we use the EUS to evaluate more detail, and then if needed, then we can direct inject the cyanoacrylate to the gastric varices. But of course, it's still not become a routine in the clinical practice. I don't know.
Serge, what do you do?
So we are doing a lot of gastric varices with EUS these days. Our threshold is at least 15 to 20 mm. If it is a varix that is smaller than this, then it is probably not worth the time, effort and money to pull out an EUS scope, because standard endoscopic cyanoacrylate will do the job well. If it is larger varices or carpeting of the fundus, those are situations, and we know that occlusion is needed either as a secondary prophylaxis or in primary prophylaxis in patients who come from far away or do not want to maintain that risk of bleeding. So obviously for primary prophylaxis it's an option that has to be discussed with the patient, but for those patients we bring out EUS. So we have done about 82 or 83 of these cases in the last two years or so. And I mean, we have gone up to varix that is approximately the largest varix was 7.5 centimeters. we have realized that, so we do things a little differently, our techniques are a little different. We do not inject in the varix if possible. We go down to the feeder. We trace the feeder back to the splenic vein to make sure that we are in the right place. It's either the left gastric, the posterior gastric, or the short gastric. We isolate the vein. We again trace it back to the varix, and just before it is going to enter the varix, that is where we occlude it. So we end up occluding the whole associated shunt on the downstream pathway in about 30 to 40% of the cases. So in fact, we have published this technique now. It's called ETSO, EUS guided transgastric shunt occlusion. We published it for hepatic encephalopathy very recently. Last month, the paper came out in American Journal of Gastroenterology. And the next paper that is going to come out is ETSO for gastric varices. So we are realizing that large varices, which would otherwise require a lot of coils and glue for, let's say, a 7 centimeter or 6 centimeter varix, some people would say don't even need to go with EUS for these cases because they are better tackled with BRTO. But let's, for the sake of discussion, consider if we were to do a 6 centimeter or even a 5 centimeter varix with EUS. We would probably want to pack it with, let's say, 6 or 7 or 8 coils, and a lot of glue would be needed. But if we go down to the feeder, we are able to do that with maybe 1 or no coils and just glue. So that is one of the papers has been published. One of the papers is now in submission, and our experience of about 80 odd cases where we have done a comparative study between coil versus no coil. That is also again now in the pipeline, because while it sounds blasphemous that we do not use coils, so because EUS coil glue has been kind of standard of care. It has been there for a while now, and there are always concerns that the glue might embolize, but when we are using undiluted N-butyl cyanoacrylate, that polymerizes very rapidly, and it polymerizes right at the site of injection, and we can see that on EUS. We are able to see the polymerization in real time when we were using coils, and we realized that we probably do not need even coils. The polymerization and the glue nidus formation happens right at the site of injection, especially when we are injecting against the flow. And these are nuances that have very significantly changed our practice. Now that said, this is a single center experience and obviously needs external validation. So again, I am not endorsing that at this stage, but there is a lot of developments happening in this field, and that is why this is a very exciting field.
When do you refer patients for BRTO part? Or?
So in our practice right now, pretty much all gastric varices we are able to do EUS. For hepatic encephalopathy, when we are closing off shunts, because BRTO is the standard of care, we first offer the patient BRTO. So in the paper that we published, out of the 9 patients that required shunt occlusion, we first offered them BRTO. 7 of them chose 2 of them opted for BRTO, because BRTO is a more expensive procedure in our setup. So out of the 9, 7 of them said that we cannot afford a BRTO, and that is when we took them in for an experimental procedure. So yes, we offer BRTO upfront for all patients for encephalopathy shunt occlusion. For gastric varices, pretty much all patients we are able to close with the EUS.
And besides these 2 indications, what are the other indications that you use?
That's a beautiful question, sir, because I believe that somehow the perception in the general community is biopsy, pressures, and gastric varices. That is all endohepatology is, but endohepatology is a lot more. Pressures, so before we come to that, I think we can just talk a little bit about pressure measurements. So we do not have that echo-tip needle. That's okay. I somehow feel that specific needle has driven all the discussions of EUS pressure measurements. EUS pressure measurements does not require a specialized needle. We can do it very easily on our transducers. So we are doing it now, and I know that Dr. Lesmana is doing, and he has already published that technique, and we are also going to publish a video of our technique. I'm pretty sure it's going to be pretty much very similar, because we started doing it in last October. So that's probably around when your paper also came out. So I was very heartened to see that paper that, you know, what we are doing is not going to be chided by the scientific community because the same thing is being done at completely different center. So what are your thoughts on the clinical utility of EUS portal pressure gradient?
Yeah, I think it is considered as quite important, yeah, in clinical practice, because we know that when I first time trained in ILBS for the portal pressure, so I know that there very rare at center or institute even that they are performing, I mean, a lot of upper GI endoscopy for varicose screening, and they also do the HVPG. But I think portal pressure measurement is, to me, is very important, especially nowadays that we know that like disease such as like fatty liver, I mean MAFLD, that now it's showed that early portal hypertension can happen even without any significant fibrosis, and we know this mostly the portal hypertension, even early portal hypertension, is not always in line with the fibrosis progression. So I think to prevent the early complication of portal hypertension is very important. And in my clinical practice, I've seen many times that most patients not tolerable with high dose of the propranolol. So I think it's in this kind of scenario or setting that looking for the portal pressure is very important. However, for the HVPG, I know it's still is considered as a gold standard, even though it's an indirect measurement. It's would need dedicated cath lab, of course, like in ILBS, everything is all comprehensive in one center. But I think if we look at many centers, sometimes it's very difficult that you have to consult the radiology first, and then the procedure cannot be done within one day because of a different department, different issue. So if you use or routinely the EUS, then and then you already mastered EUS, and you can do, let's say, like vascular evaluation and liver biopsy, and then the EUS guided portal pressure gradient measurement. Then you can do within the one day, and then just for the patient is very comfortable. I mean, to undergo that's many, I mean, procedures, several things that only within in the one day, and then maybe only one time sedation for the patient. Yeah, I don't know. Maybe Dr. Manoj, you have any comment?
The cost is the only issue with us for US guided portal pressure measurement, because doing HVP from femoral or jugular route is much less costlier. That is the problem. You need to give anesthesia to the patient. That's the risk for aspiration, although less. But these are the problems. Any other area where you use US guided intervention in hepatology?
So may I just add a little bit about the portal pressure, and then I'll come to that. So EUS portal pressures have, I mean, again, there's a lot of rage about it, but the scientific evidence is relatively limited. That is because HVPG has been the standard of care, and we have such a large body of evidence in stratifying outcomes. That is what matters. Just measuring pressures is not what matters. What matters is what is the information I am going to be able to give either to the patient or to a clinical researcher who's looking at pathophysiology. It should either add to knowledge or add to patient care, whatever we do. So as of now, for cirrhosis, EUS portal pressures, we do not have large enough body of evidence to give clinical correlates or pathological correlates. We need more time. And the moment we add propofol or a deep sedation to the mix, we encounter untackled variables. So there's a lot to unpack here. So I mean, my enthusiasm for EUS portal pressures is relatively limited in cirrhosis, but I do have a lot of enthusiasm where in pre-sinusoidal portal hypertension. That is where HVPG is is miserably failing, because pre-sinusoidal portal hypertension, we really do not know how it evolves, how it responds to beta blockers. We think it does, we do not know for sure, and this is where the opportunity lies. And that is why we have now started using EUS portal pressure measurement and portal pressure gradient in pre-sinusoidal portal hypertension. We are trying to measure the direct portal pressure and the IVC pressure. There's no point going into the hepatic vein. It is thin and narrow, and reliable readings are relatively harder to come by. And usually in pre-sinusoidal, you have a large enough caudate lobe to help you go into the IVC, and we can measure a true portosystemic pressure gradient. I like to call it PSPG, portosystemic pressure gradient. And that is where we, especially in India, where we have so much of pre-sinusoidal portal hypertension, we will add value. I do believe that. So, yeah.
I think one question I want to ask Dr. Manoj regarding that this evolution of the innovation technique. Then what's your opinion to incorporate in the training curriculum as a GI doctor? Because we know that like endoscopy for pharyngeal bleeding seems like already become the standard training for all the GI fellow GI doctor. Then now comes the innovation in the US, and maybe in the future, I'm not sure yet, but this seems to be the promising tool that as mentioned about that, like US guided coil and then other things. But how do you think about this kind of advanced procedure, and then will be incorporated in the future to the training curriculum for the GI fellowship?
Yes, because EUS is now available in almost all the major centers. So previously, as we know, ERCP is already a part of the curriculum. So EUS should also be part, and most of the centers are already giving training to their fellows regarding EUS also. So
yes, please.
Yes, yeah. Sir, please.
In measuring portal pressure, like US is a new thing which we have done. Now we had started puncturing directly with the 25G needles, right? So why can't we now look at the tools, how to non-invasively US guided, like we can clearly see the portal vein, we can see the diameter. Why can't we, like the cardiologists, they have been doing since ages, non-invasive measurement of portal pressure. So why don't we standardize these techniques these days? Because this is high time when we can clearly see the portal vein on US, you can see the hepatic veins clearly, and you can see the IVC. So the gradients can be calculated. The only thing is we have to develop that kind of software which can measure the flow, because I understand this, the low flow state as compared to the arterial pressure, but at least we can measure the size, because this pressure gradient is basically a product of pressure and resistance, basically flow rate and the size of the vein. So these are the things which we have to look into it. Secondly, this is the coil. Now we have all the tools. Earlier, whenever we used to see the gastric varix, we used to do endotherapy, seeing the foot, which were visible endoscopically. But now we have seen multiple times where there are the portal vein, the gastric varix is not visible, there are collaterals. So this comes the competition between US guided coil, which you are referring to earlier, and the second thing is about the Borto and other procedure, interventional radiology procedure. So now we have to have clear algorithm which patient should go to a BRTO or the PATO or these procedures at the state at the first end itself, instead of doing puncturing these. Because what we have observed is over a period of time when we have these large fundal varices, we used to do glue. And within a week or so, they used to come back with bleed. And there is a new collateral used to come up. So these are the patients we have to categorize. They should not be do endotherapy at the first end. Rather, we should submit them for interventional radiology procedures. Your comments or any thoughts on this?
So very valid concerns. I'll take the first one first. Non-invasive measurement of portal hemodynamics and portal pressures has People have attempted it, people have tried to use Dopplers, people have tried to use azygous vein Dopplers, because we can see the azygous vein very well. But as opposed to heart, where there is just one straight pathway, it is left atrium, right atrium, right ventricle, pulmonary vasculature, back from pulmonary vasculature, left atrium, left ventricle, out. In cirrhosis, things are never straightforward. Which collateral pathway will open up, it is uncertain. If a splenorenal shunt opens up, then the flow in the portal vein will be reduced. If a paraumbilical opens up, the flow in the portal vein will be increased. So that really, the kind of collaterals that open up really complicate hemodynamics in ways that we cannot possibly account for. So we've actually, when I was doing a research project in Italy, we published this paper when we looked at about 130 odd patients who had shunts with cirrhosis, and 38% had more than one shunt. That was more than one significant shunt, more than 6 millimeters. So if there are multiple shunts, we really cannot account for, and more than a third of these patients will have multiple shunts. So portal hemodynamics, how much of this is a consequence of resistance into the hepatic circulation, and how much of it is accounted for by these odd collaterals that are forming in different places, becomes very hard to kind of assess. So while I've really tried to work on these non-invasive Doppler measurements, it really does not give us very good data, and that is why I believe that pressures probably will hold more value, and while this requires more work, I completely agree. Coming to gastric varices, I would agree that there's a general consensus that for larger gastric varices, we should submit to IR for BRTO. However, as we are about to publish our own data, and we've already published one paper, entire shunts can be obliterated very easily with the US. The whole procedure takes about 15 to 20 minutes if we inject in the right place. So that requires head-to-head comparison, requires validation, and I think the data will evolve over time.
My only concern is even with the larger shunts. So there is a theory, proximate theory, you must be aware of that. So because we also felt the size of the varix doesn't meet, is the collateral which are feeding that. So if their inflow is more, if their outflow is, you have to block both inflow and outflow. The problem here is, even if you obliterate the fundal varix with a coil and you injected good amount, because the volume of cyanoacrylate is decreased significantly when you are using coil along with that. That point I agree. We have published our own work. We have worked for cyanoacrylate with glue and without coil. Glue with coil and with glue alone. So the incidence of complication obviously came down, and we around 34 in the both groups. The problem arises, my concern is, even in spite of doing good work in couple of, we have seen, I think, more than 100 cases now. So those patients who had large shunts, large varices, they recurred, and the new, collateral started feeding, which we thought it is a very minuscule, and we left it. It opened up and it became big, and within a week the patient came with a massive bout of bleed. So I've seen 2-3 such patients. Ultimately we had to do BATO on those patients. That's what I'm saying. So we have to study the anatomy, and we should now focus more, rather than we have as a protocol we have started doing before doing all these procedures, US guided coil plus triphasic CT to map the collateral as much as possible.
Very valid point, sir. I think this requires, more data is to come.
And the future would be probably AI-based algorithms. For example, there are algorithms based on CT scan where they measure the portal vein size, portal flow, and many other parameters, and then the AU-ROC is more than 0.95 for predicting invasive portal pressures and HVPG.
So, sir, coming to the other indications, that is something that we believe that there is so much more in endohepatology. One of those, so just to name some of them, one is EUS RFA. Now, for those caudate and the segment 2 lesions, small lesions, which we cannot RFA with percutaneous, I think that works very beautifully, EUS RFA. Other than that, shunt occlusion, as I mentioned, this will be an interesting application of EUS for hepatic encephalopathy. And it's vascular diseases, it's pre-sinusoidal portal hypertension, EHPVOs, NCPFs, where we see that there's going to be a lot of involvement of EUS. Especially for EHPVO, we have PCC, portal cavernoma cholangiopathy. And often these patients come up with symptomatic portal cavernoma cholangiopathy with a stone. Now, doing an ERCP in these patients is always tricky and scary, because you do not know where you will cut and how you will land up with a bleed. You can keep a fully covered SEMS for posterity's sake, but there's always that concern of blocking the cystic duct and causing cholecystitis. So it is not straightforward. Where I find EUS gives us a lot of benefit is it tells us where the collaterals are. If there are no peripapillary collaterals, I do not have the worry. I can give a cut and safely do things with a lot more safety. If I know that there are peripapillary collaterals, then I approach things differently. So that is one place where I feel that EUS gives a lot of value. The other place where EUS has really started changing practice is Bud Chiari. EUS in Bud Chiari is currently not very well described, but we started doing it for our patients, and we've done about 37 patients now. The preliminary data has already been submitted to APDW right now. It's an accepted abstract now. We found that we are able to visualize the intrahepatic vessels in much better detail, specifically the pericaudate area. And a lot of patients who were initially planned for dips, we were able to convince our radiology colleagues that, you know what, the hepatic vein is visualized, is so much farther away from the IVC, and you can probably go for a puncture through and through the thrombus and go for a hepatic vein stenting. Now that has real value, because instead of a shunt, now we have physiological flow. So in 37 odd patients, we were able to do that for 3. That's not a large number, but for those 3 patients, instead of a shunt, we have physiological flow. So I believe that and as our experience grows and our IR colleagues' reliance on our experience grows, I believe that this is a space that will have more value.
We are running out of time. We have discussed too much. So then I thank Dr. Rinaldi, Dr. Saj for this interesting discussion. Then after 10 minutes, we'll move on to the next session at 9 o'clock.
A very good morning to all. We welcome you on this day 2 of ILCC. We start with our keynote lecture on hot and cold HCC, does it matter for therapy? I would like to call upon our chairpersons, Dr. Vijay Kumar, Department of MCM, ILBS, Dr. Nirupama Trihanpati, Department of MCM, Molecular and Cellular Medicine, ILBS, Dr. Rajesh Gupta, Department of Gastroenterology and Hepatology, AIG Hyderabad, and Dr. G.S. Lamba, Department of Gastroenterology, Shri Balaji Action Medical Institute, New Delhi.
Hope our speaker is here.
It is an online
session. So can you please start it?
Yes. You may please introduce our speaker, ma'am.
So Dr. Shyam Kotalil is the hepatitis B person, and I believe I know him from last 15 years. He does the most of the HBV therapy and therapies, and most of the systemic therapies are led by his group. And now we will listen the hot and cold HCC. Does it matter for the treatment? And I believe that he will come up with some therapies there again.
Thank you, Nirama. You can see my screen?
Yes, we can see, sir.
Thank you. Thank you. So first of all, congratulations on this meeting. And I apologize that I cannot be there in person. Thank you for the organizers to asking me to give this talk. These are my disclosures. Hepatocellular carcinoma is common worldwide. It may differ what etiology that leads to hepatocellular carcinoma. In most places, developing countries like Africa, southern parts of Asia, the etiology seems to be viral hepatitis. However, other places may be alcoholism and metabolic associated MASH are premier causes of hepatocellular carcinoma. But regardless of that, hepatocellular carcinoma is very common and is rapidly increasing with a high degree of mortality. Each individual etiology has its share of risk factors associated with hepatocellular carcinoma development. Hepatitis B has the highest risk factor, followed by Hep C, alcohol, and diabetes and metabolic factors. However, most of these people have multiple risk factors, and then they can actually increase the risk of developing hepatocellular carcinoma. I'm not going to go into the details. You have extensive discussions of it. Most of these carcinoma go through a process of cirrhosis. There are two important pathological mechanisms that is important. One is the necroinflammation that is present in all of these etiological types and mainly contributed to a gut leak syndrome from gut microbial translocation that exists in people with advanced liver disease. Now, I am an infectious disease doctor, as Dr. Nirupama mentioned. Hepatocellular carcinoma, once diagnosed, most people die within 6 to 9 months. And that's the best thing we can do is to prevent an early diagnosis of hepatocellular carcinoma. So the emphasis has to be about diagnosing people with risk factors and treat them and reduce their behavioral as well as antiviral therapeutics you can employ in reducing the transmission of the disease. So you can either detect them earlier or you can actually prevent the development of hepatocellular carcinoma. I just want to point out some of the studies that we did. Looking at about 1 million cases of patients with viral hepatitis, looking at the attributable risk and hazards ratio associated with the risk factor and the development of carcinoma. And first, let me give you the benchmark that we use for smoking. So this particular bar diagram shows you that patients who smoke 1 pack a day have about 15 times hazards ratio more than people who don't smoke. And most of us understand that that's a risk factor. Smoking is a well-accepted risk factor for development of pulmonary cancer and many other cancer cell types. But what is surprising is that if you do have surface antigen as shown in the blue diagram or untreated hepatitis C in the green, they have equal risk of developing hepatocellular carcinoma. I think this is something that we have to reiterate in the primary care setting. People can be screened and prevented from developing hepatocellular carcinoma. However, the topic I was asked to discuss was about cold and hot tumors of hepatocellular carcinoma. If you look at the left side, that's a diagram that represents hepatocellular carcinoma this we call it cold tumor because you have a lot of cells that hepatoma cells, you have cancer-associated fibroblast, and you also have a lot of immune cells such as MDSCs, extracellular matrix cells, and dendritic cells, and other cytokines. What you actually do not see are the lymphocytes. And hence, this is considered a cold tumor. If you look at the right side, you actually do see mostly T lymphocyte, B lymphocyte, and macrophages and natural killer cells, along with increased expression of inflammatory cytokines. A peculiar factor is that you actually do not see PD-L1 expression, which is expressed in non-T cells in the cold tumor, while you have a lot of PD-L1 expression on the right side of the tumor. So we'll talk a little bit about what the significance of this and how we can actually use this information to target hepatocellular carcinoma treatment. So the cold tumors don't have T cell infiltrate. They have more regulatory phenotype, regulatory cytokines such as IL-10. They don't have high PD-L1 expression. They have increased expression of cancer-associated fibroblast and increased MDSCs. The hot tumors, on the other hand, have a lot of T cell infiltrate. They have pro-inflammatory cytokines and increased expression of PD-L1 and increased particularly CD8 T cells and increased tumor-associated macrophage of the M2 phenotype. These are amenable to immunotherapy, and that's the key difference here, is that they are actually amenable to immunotherapy, while the cold tumors are actually not amenable to immune checkpoint treatment. Just to understand the tumor microenvironment, all the different cell types constitute the liver microenvironment in the hepatocellular carcinoma. So there are B cells, T cells, and invariant and NK cells come in. They differentiate into CD4 and CD8 cells. Neutrophils are an important component. They can recruit other cell types by using chemotaxis. Dendritic cells are important in priming adaptive immune responses, particularly monocytes. Monocytes that usually have a monocyte-derived macrophages that populate the liver cells. Then also embryonic yolk sac-derived Kupffer cells become component of the monocyte-derived hepatic macrophages in the tumor environment. The three components to remember is that there is a continuous antigen stimulation, particularly in conditions like hepatitis B that leads into hepatocellular carcinoma. And in terms of tumor antigen associations that are presented to the T cells, there is a lack of co-stimulation that leads to energy as well as more a regulatory phenotype of the T cell responses that you see in the cells. So hence, there is an imbalance between the inflammatory response and the regulatory response. And when the regulatory response comes up, there is less inflammation, less infiltration, cold tumor. And if you have more pro-inflammatory response and cytokines, you actually have a hot tumor with a lot of T cell infiltration. So what does that really mean? So this is a diagram I want to spend a couple of minutes just to understand the tumor microenvironment in hepatocellular carcinoma. Here you can see that the tumor cell, one of the key factors of tumor cells is the CCR6, CCL10 axis that predominates and that leads to the development of T regulatory cells that express CTLA4. Also, MDSCs promote the development of CTLA4 positive T regulatory cells. They secrete VEGF factors, it's been discussed at your meeting extensively, and is an important angiogenesis factor and a common target of treatment for hepatocellular carcinoma. This will lead to dendritic cells producing an IL-10 phenotype and effectively to act on the NK cells as well as effector cells in making them less potent in cytotoxic function. So basically what you are actually getting is an impaired tumor-associated antigen expression that leading to a T cell phenotype that overexpress CTLA4, PD-1, and PD-L1, LAG3, and TIM3. So this is the environment is mostly immunodysregulation and represents an exhausted phenotype of the T cells. On the other hand, continuing back to the phenomenon, you actually do see a lot of tumor mutational burden here, even though much less than what you see in melanomas. The beta-catenin mutation will lead to reduced CCL5 or anti-secretion. That leads to IL-10 secretion. That again due to increased VEGF secretion, and that leads to an environment that leads to regulatory phenotype. Increased TGF-beta secretion from TAM M2 macrophages and IDO secretion from T cells recruited mainly by neutrophils that lead to an environment called immunosuppressive tumor microenvironment. So the immunosuppressive tumor microenvironment predominates in the cold type of tumors where there are more regulatory T cells, inhibitory B cells, and MDSCs, while the impaired T cell predominates in the hot tumor where there's more lymphocyte infiltrate, but they have less response. How do we study this? In our laboratory, we use a wide variety of mouse models. Mouse model with the normal immune system, that is the AAV-based HPV, so we can study the HPV natural history in this mice. Then we use a variety of humanized mouse models to do that. There is humanized liver that can be done by orthotopic liver transplantation, the humanized reconstitution of the PBMCs and the partial immune system by transferring CD34 positive hematopoietic stem cells, or a combination of both of these, where you can actually put the same liver in the liver, that you can study both the autologous liver as well as autologous partial immune system. However, the limitations of all animal models is that you have to confirm your findings in patient studies. So how does this help? So this is created by Li Shansu from our institute, who is a master of making all these different animal models, where you can create an NTCP-based HPV, either with a mock transmission or HPV-induced hepatocellular carcinoma. You do see infiltrates. These dark spots are the CD68 monocyte-derived macrophages. They also have a monocytic lineage, the CD14, the CD16 lineage. However, what they don't have is they don't have a CD86, which is the M1 phenotype. It's a pro-inflammatory type of macrophages you don't see. Well, you do see the M2 phenotype predominates, that is 163 and CD10206. These are two markers of the M2 phenotype of the macrophages. And this is an aggressive type of tumor that suppresses T cells, more regulatory function. You can easily see that in patient liver biopsies. These are the liver biopsies of patients with chronic hepatitis B or even hepatocellular carcinoma. You show the same degree of finding, increased CD68 positive CD206. So a tumor-associated macrophage of the M2 phenotype is a critical factor that you actually see in many types of cold tumors. So let me go back again, the mechanism of exhaustion that do exist here. So even D cells can prime a CD4 cells adequately with the contact mediated help. The CD24 cells will differentiate and help into a T cell that helps them to become a cytotoxic T cell lymphocyte. However, in many situations like that you see in liver, where you don't really see this kind of T cell degrading into a cytotoxic T cell. However, through ICOS ligand and ICOS, they produce a CD4 type naive cells into T regulatory 1 that secretes IL-10. Monocyte-derived dendritic cells can also express PD-L1, and if they do express PD-L1, they will inhibit the T cell function and then become a T cell environment as well. You can reverse this a lot by using these dendritic cell-based vaccines therapy and dendritic-based in cytokine-induced killer cells are all been in experimental models studied in animal models in hepatocellular carcinoma. But the concept that inadequate priming can lead to an immunosuppressive environment with highly suppressive T cell function in tumor is critical. The current treatment actually works in 4 different classes of medication that actually targets 3 different cell types. The first is, of course, the cancer cell. The targets includes the tyrosine kinase inhibitors and the VEGF inhibitors that have been shown here that works in the tumor cell by reducing the replication of the cells and reducing the VEGF activity as well as VEGF function. VEGF receptor inhibitors can also work on endothelial cells. There's the second cell types, and they have a similar effect on endothelial migration and associated factors of the tumor. The third group of the immunomodulatory agents, such as CTLA-4 inhibitors or PD-1, PD-L1 inhibitors, work on T cells. They don't work on the tumor cells, they work on the immune system. And if these cells are actually not there, they're actually not going to be functional. Hence, they don't have any role in cold tumors. Here, the color coding here shows that all the green color coded shows that these have been studied in a superiority clinical trial, phase 3 clinical trial, and showed efficacy over the standard of care. Lenvatinib is the only drug that has been shown in non-inferiority efficacy in a smaller clinical study. And these immunological agents are only being studied in phase 2 clinical trials. They are all being done in phase 3 clinical study. But these are the potential mechanism of action of the current treatment of immunotherapeutic agents. What's wrong with tumor-infiltrated lymphocytes? They contribute to tumorigenesis, tumor progression. How does it do that? It's because they're supposed to influence anti-tumor treatment. They increases PD-1, particularly in the virally induced hepatocellular carcinomas. They have induced concomitant PD-L1 on other cell types. They have an exhausted phenotype. What they represent is a failed endogenous anti-tumor immune response. So our job is to reinvigorate the response so they can actually fight back against the tumor cells. So how do we do that? The tumor cells, when they express PD-1, they express CTLA-4, they bind to PD-L1, they actually become exhausted, they do not secrete cytokine, they're not cytotoxic. The CD4 cells, they're also in the presence of tumor cell, then are primed to become a T regulatory cells that are expressing CTLA4 and not so much differentiated to Th1 cell, which is beneficial in clearing the cell types. And you can actually employ that by priming better, using better DC-based vaccines. You can also create CAR-T cells that can create a chimeric antigen receptor that is specific to a particular one of the tumor-associated antigens and be functional and supplement the lack of immune responses in that. Let me just explain how do you convert a cold tumor to the hot tumor, which is one of the topics that I'm supposed to discuss in using an example of hypoxia-inducible factor. This is something we have worked in our institute quite a bit, and it's a really good way to explain the situation, how you can convert one type of tumor to another tumor, and what's the clinical efficacy of it. So hypoxia is a pathognomic sign of tumors, and they induce vasculature and leads to reduced oxygen, and that leads to induction of hypoxia-inducible factor 1 alpha. It is a transactivating factor. It promotes tumor progression, increased metastasis, and resistance to treatment. It also induces PD-L1 in the tumor environment, and there is potential for chemo combination treatment. So when there is hypoxia, it induces oxidative C cells, reactive oxygen species lead to HIF1 alpha. You can also stimulate protein kinase C that lead to MAP kinase secretion and NF-kappa B, again culminating into increased HIF1 alpha secretion. P13K and mTOR similarly do the HIF1 alpha. There are multiple pathways HIF1 alpha can be induced in a tumor environment. When it is induced, it further leads to the secretion of VEGF, PDGF, and angiotensin II. All factors are lead to neovascularization, angiogenesis, and tumor progression. So HIF1 alpha contributes to tumor progression, tumor metastasis in patients. So this is the work from our group. Chris Bailey and Hong did a really, really great study which was published last year in JCI, just exactly how this synergistically work in controlling the HCC. So if you look at the tumor environment, there is increased PD-L1 secretion, there is increased MDSCs and TAM. And these cells, they induce hypoxia in the tumor environment, leading to HIF1 alpha increase. The increased HIF1 alpha will lead to PD-L1 expression. And this PD-L1 makes the T cells ineffective in clearing the particular tumor. So blocking this HIF1 alpha has the benefit of blocking the PD-L1 expression, and then the T cells can become active and killing the tumor cells. On the other hand, if you take normal tissues, which normally do not express PD-L1, HIF1 alpha can also induce an interferon response. And this interferon response will then induce an inflammatory condition that lead to PD-L1 expression and have the same effect of blocking the T cell activity in the normal tumor tissue along the tumor environment. It can also have an effect in blocking anti-tumor responses. How can we take advantage of this particular thing? So what they did was they actually first looked at this question: what happens if you block HIF1 alpha secretion in a normal mice with a competent immune system such as C57 Black 6, or a mouse model that is like NSG who has no immune system? Here they used ileum or economycin, which is a naturally antibiotic that blocks HIF1 alpha secretion. You can see the tumor volume on the y-axis is the readout. You can see that here, when there is no immune system, economycin was less effective. When there is an immune system in C57 Black 6, the reduction of HIF1 alpha led to much more reduction of tumor volume. That makes sense that HIF1 alpha somehow is influenced by the presence of an active immune system. So what they did was then they went further and asked the question that what if you remove HIF1 alpha or the PD-L1 and with the same background, the NSG background and C57 background. So if you remove, for example, if you look at the red line, if you block PD-L1, there is less PD-L1, but if there is no immune system, the PD-L1 is blocking will have minimal effect. So it has more effect on the immunocompetent mice that's expected. Same is expected with the HIF1 alpha. If there is no HIF1 alpha, that effect is much more on the tumor growth, is much more when it is immunocompetent mice compared to immunodeficient mice. But then they made further, then they looked at combination of chemotherapy. What they did was they used economycin to suppress HIF1 alpha and concomitant with 99, which is the TLA4 antibody, or RMP114, which is a PD-L1 monoclonal antibody. Here you can see that the tumor growth is reduced with HIF1 alpha blockage. It is also reduced with CTLA4, which is the red one. But the best effect you see actually when you combine different agents, either PD-L1 with CTLA4 or economycin with the liver. So they can tell you that there is an additive synergistic effect between HIF1 alpha blockage and immunoregulatory finding. The other finding again, here we're looking at the inflammation interferon responses in doing the similar findings of creating a cold tumor and how do you reverse it to hot tumor. Here you can see we create a humanized mice model with a reconstituted with CD34 positive human C cells with the immune system and an orthotopic human liver in the same mice. So mouse has a human liver and human tissue. And then you create human hepatocellular carcinoma in the mouse model to study the effects. So if we look at the tumor infiltrating lymphocytes, you see that most of the tumor infiltrating lymphocytes are extremely exhausted, express TIM3 as well as PD1, while not so much in the peripheral blood. Then you look at, we are depleting the TNF. You're not blocking HIF1 alpha, but we are looking at blocking the interferon response by depleting PDCs. The monoclonal antibodies we use, the Lishan Su uses, is to block out the PDCs, and it has an effect on tumor growth. If you remove the TPDCs, remove the interferon alpha, it reduces suppression. That's by interfering with the PD1, PD-L1. Again, working synergistically with the same approach. So the concept here is that when you have a tumor, the tumor have a microenvironment which is increased from PD-L1 secretion and increased hypoxia. They work together in tandem to making it escape the immune response against the existing T cells and also creating an environment so that it can have more tumorigenesis and metastasis process. By combining PD-L1 and HIF1 alpha, you can target this better because they are synergistic in effect, and you can making it actually a cold tumor become a hot tumor, and making the HIF1 alpha inhibitors will make the tumor cells more responsive to PD-1, PD-L1. And that's the basis for combination treatment. You have medications right now, all the immunotherapeutic agents are into 4 groups, but they basically have 3 principles. One blocks cellular replication, that's basically the VEGF inhibitors and the TK1s. That's shown here. And then you have the one CTLA-4 that basically targets T cell regulation. And finally, the PD-1, PD-L1 will target reinvigorating of the adaptive immune responses. So let me go back on this and wrap up my presentation. So here's a tumor, it's a cold tumor. If you give him PD-1, PD-L1, it has minimal effect. So how do we make sure that they're more amenable or by the way, we convert them into a hot tumor. So if you use VEGF inhibition or tyrosine kinase inhibition, what it does is that it does promotes the cytotoxic T lymphocyte production, even though it will be exhausted, by increasing the DC proliferation response. But it also blocks the T regulatory cells by reducing its differentiation. It blocks the MDSCs because the tumor cells is now changes with treatment, and also reduces the M2 TAM, tumor-associated macrophages. Altogether now, you actually have a hot tumor where you actually have T cells, they're active, they're exhausted phenotype, there may be expression of PD-1 there, and now they are more responsible for either CTLA-4 based treatment, PD-1 treatment, or a combination of that. And that is how you can sequentially convert a cold tumor and much further respond. This is tricky because most of the time you're actually not doing a liver biopsy and looking at PD-1, PD-L1 or CTLA for expression before you determine treatment. But this is the logic of converting a cold tumor to a hot tumor. Again, I would say prevention is the best treatment for hepatocellular carcinoma. None of the treatments are game changers at this time, although we have a lot of therapeutics available than we didn't have like a few years ago. Recent studies shown in the hot and cold model of HCC and has therapeutic implications with immune checkpoint inhibitors. Hot tumors has T-cell infiltrations, exhausted regulatory T cells that are amenable to treatment with immune checkpoint inhibitors. Hence, a treatment for HCC can be designed to influence tumor microenvironment and convert cold tumors to hot tumors, so the combination treatment can be highly successful. Most of the work was done by Lishan Su in the mice model and Chris Bailey, Yin Wang in our institute, and the rest of the collaboration, and thanks for the patience. And finally, again, thank you very much, and I hope you all have a great conference.
Thank you, Dr. Shyam, for an exciting and thought-provoking talk. Can we have 1 or 2 questions? Dr. Sonal? Yeah.
Good morning, Dr. Sonal Asthana from Bangalore. Thank you, that was a fascinating talk. There's some parallels between sort of Th1 and Th2 response as we used to talk about in the, say, responses to hepatitis C treatment before. And at that time, the T-BET pathway was something that we really talked about. I'm just curious to know if there's been any work in seeing whether the TBET pathway and its transcripts are actually overexpressed in a tumor suppressor versus a cytotoxic response?
Yes, thank you. Very good question. So the TBET pathway TIGIT have been involved in part of the exhausted phenotype of the T cells, predominantly seen in the virally induced hepatocellular carcinoma. So that is true for viral hepatitis C, viral hepatitis B, and as well as those tumors that are induced by that. So those pathways do there. Unfortunately, we don't have really good therapeutics that has moved forward in the clinical development that would target this. However, because of the co-expression of these markers along with the other markers of CTLA4 and PD1, you will hit most of these cells and exhausted cells by using CTLA4 and PD1.
Thank you so much.
Dr. Shyam, can I have one question? So as the cancer-associated fibroblast may have the PDL1, still the cold tumors don't have the PDL1? Because generally PDL1 ligand is present on all these fibroblasts and APCs. Can you please?
Yes, so but the PDL1, so it is a dynamic effect, right? So PDL1 expression is usually in non-T cells and PD1 expression is usually in the T cells. When you have a microenvironment, when you have an overexpression of PD1, which many of these cells, exhausted cells have, that will also induce expression of PDL1. So there is a dynamic effect where actually there is more and more PDL1 expression on all the neighboring cells, including the fibroblast and other cell types. So if you don't have T cell infiltration, that effect is actually not there. So relatively speaking, there will be less PDL1 expression. If there is no T lymphocytes there, even if you have small PDL1 expression, that don't really have a big effect on how this tumor will respond to PD1, PDL1. Because the hot tumors in general are not going to respond to checkpoint inhibitors with PD1 or CTLA4 alone because they don't have T cell infiltration.
Thank you, Dr. Shyam, once again, and now we conclude this session in the interest of time. Thank you very much for participants.
Thank you, the chairpersons. Thank you, Dr. Shyam, for joining us.
And now we move on to the session 9, Systemic Therapies in the Context of HCC, where we are going to first have a debate followed by 2 lectures. And I would first like to invite the chairpersons, Dr. Anup Saraya, Department of Gastroenterology and Hepatology, AIIMS, New Delhi. Dr. Hema Mala Elango, Department of Gastroenterology and Hepatology, MIOT Hospital, Chennai. Dr. Samagra Agarwal, Department of Gastroenterology and Human Nutrition Unit, AIIMS, New Delhi. The moderators for the session, Dr. S.P. Singh, Department of Gastroenterology, SCB, Medical College, Cuttack. Dr. Anurag Govil, Department of Gastroenterology, Jaipur. Dr. Supriya Malik, Department of Radiation Oncology, National Cancer Institute, AIIMS, New Delhi. I invite all of them to take their seats and begin the session.
Good morning, everybody. So we welcome you all in this session, and there will be a debate on TKI versus immunotherapy. And the first speaker who's speaking in favor of TKI is Dr. Kaushal Madan. He is a director and head of hepatology division at M.I.C.E Hospital, Saket in New Delhi. So it's over to Dr. Madan. Dr. Kaushal was here. Huh? He's there.
Sorry. So good morning, everyone, and thanks to Ashok and Dr. Sareen for inviting me for this particular meeting and giving me this opportunity. So before I move on, just remember what Dr. Shyam Kotalil said about hot and cold tumors, and then we'll come back to that when I move forward with my talk. So it's a difficult task, TKI versus immunotherapy, speaking in favor of TKIs. So if I ask you if you have any ailment, what would you rather have, a single pill a day versus repeated injections for many months or years? Of course, I understand the pill has to be at least as efficacious, if not more than the injections, and to be associated with at least lesser side effects as compared to the injection. So let's see whether that's true or not. Most societies have recommended that immune-based therapies or atezolizumab, bevacizumab, or durvalumab, tremelimumab should be the first line. Similarly, our society also says that, but in the fine print, they also say, if not feasible, then TKIs, sorafenib, or lenvatinib can also be considered as first-line therapy. So let's look at the efficacy. Let's compare the two. Let me try to convince you that TKI may be as better, if not superior. So let's look at the phase 3 registration trials of these two particular regimens. So this was the REFLECT trial based on which lenvatinib got approval. 954 patients, child's A, ECOG less than 1, lenvatinib versus sorafenib. And as you can see, lenvatinib scored better over sorafenib in terms of progression-free survival, which was significantly better. And when they looked at the overall survival, that was about 13.6 months versus 12.3 months, not found to be significant, but it was a non-inferiority trial, so it was approved. It was an open-label study. Let's come to IM-BRAVE, based on which atezobev got approval. It was also an open-label study. So both are similar. So nobody can say that one was inferior to the other. Both were open-label randomized control trial, 501 patients, median progression-free survival being the co-primary endpoint, 6.8 months versus 4.3 months. Whereas in the REFLECT trial, 7.4 months, which was numerically better than atezobev. However, there is no head-to-head trial. We cannot compare the two. I agree, but numerically better. That's how oncologists work on. They look at 2 months better survival, 6 weeks better survival. So this is 7.4 is better than 6.8, no doubt. Let's look at the updated analysis of IM-BRAVE study, 12 months beyond the primary analysis, and the median overall survival was 19.2 months. Remember this magical figure, because the proponents of atezobev always talk about 19.2 months overall survival, maximum which has been achieved by any anti-cancer drug in HCC. So remember this figure, 19.2 months, because they keep telling you this. And a complete response rate of 8%, which is significant. No other drug has achieved that. Now, very few RCTs, so let's look at real-life data. Real-life data of lenvatinib, the elevator study, 205 patients, 14 centers. When they took REFLECT in patients, all those patients who were also falling in the inclusion criteria of the REFLECT trial, median OS 15.6 months, which is good. Median progression-free survival 8.1 months, which was significantly higher than REFLECT out. And when they saw patients who had LB grade 1 with preserved liver function, these are the same patients who were included in atezobev trial also, 19.9 months. So go back to that 19.2 months magical figure. So even lenvatinib is able to achieve 19.9 months of overall survival, 8.6 months progression-free survival. Another data, 21 centers from Japan, CTPA, median overall survival, lenvatinib, 21 months. And patients who had LB1, 25.3 months, almost 2 years you are getting with lenvatinib, patients who are child's A and good liver function. Then the REFLECT trial, subgroup analysis, they analyzed patients at landmarks of 2, 4, and 6 months, divided them into responders, non-responders. Responders, those who had complete response or partial response as per MRESIST versus non-responders, and responders, look at this, 21.6 months median survival. You can decide at 2 months whether they are going to have this kind of response or not. If they are not, you can decide to stop the therapy. So 2 months, good enough to decide. 2 months, 4 months, 6 months, whether the patients are going to achieve this much of overall survival. And complete response rate of 5%. They talk about 8%, 5% is not different. Now let's look at real life data of atezobev. This is 147 unresectable HCC from Germany and Australia. IM-BRAVE in those patients who were meeting the inclusion criteria for IM-BRAVE. Modest median overall survival of 15 months. And those who were IM-BRAVE out, dismal, 6 months. So even with IM-Brave in, it is a modest overall survival of 15 months. Even in LB1, it is as good as only 15 months. They talk about 19.2 months, real life setting, 15 months. More data, multi-center, USA, Europe, Asian patients, 433 patients, excluded child's BC, and again, median overall survival modest, 15.7 months, real life data. They talk about the registration trial, 19.2 months, but all real life data does not go beyond 15 months. Another real life data, Asia, North America, Europe contributed 216 patients. In child's A, at best they could achieve a median overall survival of 16.8 months and dismal survival in child's B, which was 6.7 months. And the best radiological response, in their original trial they talk about 8% complete response rate. Here it is only 1%, nothing close to 8%. Real life data from India, small number of patients, 67 patients. Yes, CTPA, they showed 21 months overall, median overall survival, but this is what is more close to real life. This was from Medanta. Again, I agree, it was a small number of patients, but this is what all of us see, a median overall survival of 8 months and significant side effects. Almost 30 to 40% patients have significant dose-limiting toxicity. And finally, the meta-analysis, largest data, 47 studies, 5,400 patients, best data up till now for Atezobev, pooled median overall survival, modest, only 13.8 months, and pooled median progression-free survival, 6.86 months. This is similar to the registration trial of lenvatinib. They also gave a median overall survival of about 13 months and progression-free survival of 7.4 months. So Atezobev possibly, in terms of efficacy, is not better than lenvatinib. What about CTB-B patients? This is a problem. We all face this. Patients who are CTB are not fit for any of these therapies, and most of the trials had excluded CTB-B patients. So you can get real life data, on this from real life. Atezobev, I don't believe there's only 1 minute left. Atezobev versus lenvatinib. Lenvatinib, better median overall survival, 13.8 versus 8.2 months. Impact of etiology, hot and cold tumors. NASH is going to be the most important cause of HCC in near future. 130% rise in HCC. And NASH tumors are cold tumors. You just heard Dr. Shyam Kotalil tell you about it. So this is a Nature paper, meta-analysis of 3 large randomized control trials, Checkmate, IM-Brave, Keynote. Patients who had non-viral HCC, no impact on survival. Viral HCC, yes, Atezobev was better. And when you looked at median overall survival, again, Nature study, in NAFLD patient, median 5.4 months, 8.8 months. Is NAFLD maybe a contraindication for patient using Atezobev and possibly a need for using lenvatinib in these patients? Second, obese NAFLD patient. Obesity is associated with resistance to anti-VEGF. So this is a study in animals which suggests that patients who, the animals who were given bevacizumab and were obese were likely to have larger bulk of tumors. So obesity, bevacizumab does not act. So obese NAFLD patient may be a contraindication for using Atezobev. Now let's look at lenvatinib. Does it get affected by etiology? Lenvatinib, 1,232 patients, multi-center study. In NASH, median overall survival, 22 months. Non-NASH, good enough, 15.1 month. Another study comparing these 3 drugs, Atezobev, lenvatinib, sorafenib. In the NASH population, lenvatinib gave an overall survival of 21 months, whereas in non-NASH population, it did not matter, and the overall survival was almost similar in the 2 groups. So I'll skip this. Coming to the adverse events, I'll just talk about the immune-related adverse event because we are getting late. So immune-mediated adverse events, almost 5% patient had grade 3 rise in AST, ALT. And it is not only hepatotoxicity, it is toxicity in the GI tract, skin, endocrinology, and interstitial lung disease, which happens as a immune-mediated complication, which happens in up to 4 to 14% patient with Atezobev. And when you talk about tremelimumab and durvalumab, can happen up to 45% patients. And when we look at the meta-analysis, look at this. Variceal bleed, 11.6% in presence of PVTT. PVTT is one of the indications for using systemic therapy. Immune-related adverse events, 10.2%. Discontinuation rates, 7% with Etizobev. Another unique complication of immune therapy, hyperprogressive disease. You start the treatment and disease progresses rapidly, it runs. These are the examples. Here you started therapy, and within 4 weeks, the tumor has almost 10 times increase in size. Similarly, this patient, the tumor has become multicentric. And these are the data, both Etizobev as well as other immunotherapy are associated with hyperprogressive disease in these many percentage of patients. Finally, financial toxicity. This is what the cost looks like in patients with Etizobev and with no end in sight. You continue giving patients these expensive treatment, and this is how much it costs, and this is a subsidized cost given by the company, and these are the MRPs of lenvatinib generic and lenvatinib originator brand. Lack of biomarkers. You want to continue using these expensive and toxic therapies, you need to decide which patients or choose which patients to give it. But up till now, although these are said to be PD-L1 or PD-1 blockers, but the expression of PD-L1, PD-1 in the tumor cells has had no impact on tumor response. What about newer ICIs or immune checkpoint inhibitors? So this is tremelimumab, durvalumab. All you can achieve is a median survival of 16 months, that too by combining the two. So single one does not act. And no impact on progression-free survival. Another new kid on the block, camrelizumab plus rivosiranib. Again,
Kaushal, please.
Yeah, I'm just closing that, sir. So again, you required a TKI in addition to ICI to achieve this response rate. So any ICI alone is not effective. So I'll just skip this and come to my conclusion or summary. I summarize and I rest my case by saying that lenvatinib is not inferior to Etizobev. In real life, lenvatinib may give better median overall survival than Etizobev. Among CTPB patients with unresectable HCC, just last slide, can I have this? Yeah. Among CTPB patients with unresectable HCC, lenvatinib may provide better OS. Lenvatinib gives much better OS among NASH-related HCC than Etizobev. NASH may even become in future a contraindication to use Etizobev in these patients. And finally, Etizobev. Okay, I think I have to close. Thank you.
Thank you, sir, for that wonderful data and almost convincing us that tablets a day is better than the continuous injections. But we have another speaker, Dr. Richard Finn, from Department of Medicine and Division of Hematology Oncology from Johnson Comprehensive Cancer Center from Los Angeles, USA. He will be talking about why immune checkpoint inhibitors should be used as the first preference. May we have the speaker?
There was a recorded video, right? Do you guys hear me? No.
Yes, we can hear you.
I mean, I would have done it live, but I sent a recorded video. Do they have the video? I saw it was. Do they not have the video?
The video is there. This video is there.
Okay. I mean, I would have done it live, but they asked for a video, so there you go.
Can you turn up the volume, please, for the video? If you can start over, please, with a higher volume.
And can we have
the slides on this screen also?
From the David Geffen School of Medicine at UCLA, and thank you for this invitation to have this debate about first choice of therapy for patients with liver cancer. These are my disclosures. I want to start with a case which exemplifies why immunotherapy, specifically immunotherapy combinations, and in this case atezolizumab and bevacizumab, should be our first choice for advanced liver cancer, and even patients with some intermediate liver cancers that are multifocal. This was a 64-year-old gentleman I met some time ago with hepatitis B. Now I've been caring for him well over 2 years, 2.5 years almost. He came in with right upper quadrant pain, weight loss, significant weight loss, poor performance status. He had imaging on the outside which revealed multiple large liver masses, replacing almost the whole liver with right and left portal vein thromboses. And the biopsy showed well-differentiated liver cancer. This was done outside. He was anemic and had an endoscopy, had varices that needed to be banded. Had a history of coronary disease and hepatitis B, which was being treated. However, he was not undergoing regular screening for his liver cancer. And here you see his labs. Platelets were 465. Bilirubin was 2.4. Liver enzymes slightly elevated. It was actually Child-Pugh B7. Here you see his scans. Very large tumor here on the coronal and axial images, replacing much of the right lobe, and he has a very small left lobe. Also had some ascites. So when we look at frontline choices based on globally approved regimens, initially we had sorafenib from the SHARP study, improved OS with a hazard ratio of 0.69, improved PFS, but really had no objective responses. That was the standard of care for a long time until we had the REFLECT study where lenvatinib was shown to be non-inferior, hazard ratio 0.92. Survival was 13.6, and in modern studies, we've seen survival with lenvatinib being 19 months in the LEAP-002 study, and the control arm was lenvatinib alone. But for the first time, we had an objective response rate of 19% from patients with a TKI. And this became a good option for patients. So again, it did not improve OS versus sorafenib. That changed with the results of IMbrave 150, where now we saw a hazard ratio of 0.58, so a 42% decrease in the risk of death versus sorafenib. And in updated data, we see the objective response rate of 30% and median survival of over 19 months. And shortly after IMbrave 150, we had results of dual checkpoint inhibition with durvalumab and tremelimumab. This has a ratio of 0.78, so a 22% decrease in the risk of death. No improvement in PFS, but a 20% objective response rate. Now, based on these data, it's important to keep in mind not all of them included the same population. While all of them concentrated on Child-Pugh A, only SHARP and IMbrave 150 included high-risk patients. That is to say, patients who had main portal vein invasion or VP4. And still with that data, we saw an improvement with atezo-bev. Here you see PFS and OS for the primary analysis, has a ratio of 0.58 and 0.59. And with longer follow-up, we see that median survival is 19.2 months. And when we look at objective response, we see a response rate that is 30%. And I want to point out here, if you look, there's been some confusion about the role of IO in viral and non-viral liver disease. You can see here the objective response rate for patients with hepatitis B, hepatitis C, or non-viral are all the same, very close to 30% as compared to sorafenib. So this idea that atezo-bev and IO doesn't work in non-viral liver disease is yet to be proven, and I would say the data suggests that these drugs are active in that disease. Regardless of etiology, the side effects are well known, most of them coming from bevacizumab with hypertension and proteinuria. We don't see GI toxicity, we don't see hand-foot syndrome, and we know that this regimen improves quality of life as compared to sorafenib. Now, certainly when we look at all grades toxicity, generally they are similar between both regimens. Grade 3-4 toxicities, very similar. In fact, grade 3-4 treatment-related adverse events are higher with sorafenib. SAEs are slightly higher with atezo-bev, but keep in mind patients are on atezo-bev much longer than they are on sorafenib. But if we look at treatment-related deaths, very similar between both arms. And discontinuations are actually leading to both drugs is only 7%. Bleeding has been something that has concerned us with this regimen. And we can see here that all grade bleeding events are slightly higher with atezo-bev, 25 or 17%. But high-grade bleeding events are actually very similar. Grade 3-4 events, 6.4 versus 5.8. And most of these are low-grade bleeding events. When we look at higher-grade events, so GI or upper esophageal hemorrhages, there were 4 grade 5 related deaths, so deaths related to upper GI bleeding. However, these were all in patients with VP4 invasion. And we know that VP4 invasion increases portal hypertension, and that's why all patients receiving atezo-bev should have an upper endoscopy within 6 months of starting drug. And you can see here, grade 3-4 events are fairly similar. Here you see this is 3% versus 2.5%. Now, durvalumab and tremelimumab is also an active regimen in this indication. You can see here, durva-tremi had a survival of 16.4 months versus about 14 months with sorafenib. It's a hazard ratio of 0.78, and again, in patients without VP4 invasion. Another endpoint here was single-agent durvalumab, and this regimen showed that it was non-inferior to sorafenib, as we've seen with other single-agent IOs. Hazard ratio of 0.86, and this upper limit confidence of 1.03 is less than the cutoff of 1.08. Now, this regimen did not have any improvement in progression-free survival, and objective response rates with the doublet was 20% versus 5% with sorafenib. So clearly, an active regimen for patients who might not be able to tolerate atezo-bev or receive atezo-bev. But I would argue atezo-bev is more active, and is certainly more active, both regimens more active than any TKI option. And this regimen is generally very safe. You can see here that there are more serious treatment-related adverse events. Discontinuation rate is fairly low. The adverse events here are largely driven by immune-related adverse events. We saw those with atezo-bev at a frequency of about 10% of patients requiring steroids. With the 2 immunotherapies, we see that's about 20%, which is, again, higher than single-agent IO, where we see 9.5%. But generally, most of these events are low-grade, and we are very capable of managing them, given our experience. So our patient now has come in for follow-up. I've now been following him for over 2 years. I actually saw him today, as it turns out, and this data has not changed. He has had a dramatic response. You can see his tumor is much smaller here, starting to be calcified. It's not hypervascular. He's gained about 35 pounds back. He's actually a little too heavy now. His liver enzymes have normalized, and he has responded really well. This has not been described, at least as frequently, with TKIs. Maybe I won't say it's never been described. Certainly, lenvatinib does have a response rate of 19%. But this type of effect is really only seen with IO, I would argue. And IO doublets are clearly the most active regimens we have. TKIs still play a role. I would say if you cannot get, I would say the first question is, can you have an upper endoscopy, or can you get bevacizumab? That's the first question. Are you high risk of bleeding? Do you have bleeding risk? I think most patients have a small bleeding risk. This patient actually bled but had an endoscopy and things were under control. Then the question is, can they get IO? And if they can, I think the option is atezo-bev. If they can't get atezolizumab and bevacizumab but can get IO, then certainly durva-tremi would be an option, and perhaps even single-agent IO if for some reason they couldn't get a doublet. So in take-home, IO therapy has revolutionized the management of hepatocellular carcinoma. We really need to find a reason why not to offer a patient immuno-oncology agent, specifically a doublet. And of the doublets, atezo-bev is the most active regimen we have so far that's widely approved based on the hazard ratio of OS, PFS, ORR, and safety. And durvalumab and single-agent IO are options for patients that have contraindications to atezo-bev. But certainly if a patient cannot get immunotherapy, lenvatinib or sorafenib are still reasonable options if they have shown to be active in this disease. Thank you very much for having me. I look forward to hearing and debating with my colleague when we meet in a few minutes live. Take care. Here are my acknowledgments for all my colleagues at UCLA and certainly all the patients who participated in our research. Take care. Bye-bye.
Thank you, Dr. Finn. Dr. Kaushal Madan.
So thank you, Dr.
Hi there. I'm Dr. Richard Finn from the David Geffen School of Medicine at UCLA.
Yeah, good morning. Thanks for your presentation. I think he made 2 points about including patients who are high risk in IM-BRAVE. He talked about including VP4. Actually, VP4 are the patients who are at high risk of bleed when you start these patients on anti-VEGF. So if you look at the large meta-analysis of more than 5,000 patients, there was a 10% risk of bleeding in patients who had portal vein thrombosis when they were given atezo-bev. Second point which I did not make during my presentation was the AFP. If you look at the subgroup analysis in atezo-bev, patients who had AFP of more than 400 did not do well in terms of their overall survival. Whereas if you look at the REFLECT trial, patients who had higher AFP or lower AFP both had better response rates. And I think Dr. Finn only talked about the registration trials, whereas I showed you a number of real-life data. That's what we hepatologists do all the year round. We see patients and treat them, and then we compare it with the registration trials, and we found, and these data found, that lenvatinib or TKI is possibly scored over atezo-bev in terms of both overall survival and adverse event profile. That's it.
So I get to respond, I think?
Yes, yes, you can.
Yeah, I don't see the room. I just see myself, so it's a little challenging. But of course, you went into real-world data because you had 20 minutes for your presentation. But besides that, the way we make decisions for treatment is based on high-level evidence. The real-world data, as I see it, is very supportive of the phase 3 studies. You're not going to see the exactly same outcomes. It's trends that we look for. And when you see a hazard ratio of 0.59, that is a very significant benefit, especially when it's versus active control. You know, real-world evidence should be supportive of what we do in clinical trials, but it's never going to be the same because there's no monitoring, it's not randomized, there's no scheduled management of adverse events or monitoring of response rates. So, you know, I don't think we can put too much stake into real-world evidence other than maybe for safety. The other thing I would like to comment on is, look, I was involved in all the pivotal studies with lenvatinib. I'm a big fan of the agent, but I would not say that's going to replace atezo-bev as a first-line option. The deep responses that we see with IO are unprecedented. And these are not rare anymore. 30%, maybe even higher, to be honest. I mean, these cases where patients just have dramatic responses, and we've set the bar now. Survival now is probably over 2 years for advanced liver cancer, and I don't think anything will change that. And you have to keep in mind, the REFLECT study, the LEAP study, Himalaya, did not include high-risk patients, right? So when we take out those high-risk patients from EMBRAVE 150, we actually see the survival is over 24, 25 months. And again, that's, you know, manipulating the data retrospectively, but I think you always need to compare apples and apples, and these study populations are not the same. I see Fabio at the microphone. Is that Fabio?
Yes, yes. Yeah, I would like also to make an additional comment that even though I'm also a fan of lenvatinib, Actually, in real life, we use atezobev in overweight NAFLD patients, and it's effective. But what I would like to outline is that these meta-analysis showed that the non-viral patients apparently did a bit better, a bit less good with atezobev. But non-viral does not mean non-alcoholic steatohepatitis. Non-viral includes cancer which has arisen without any background liver disease, means alcoholic liver disease. So making it equal to non-alcoholic fatty liver disease, I think, is not evidence-based.
The other thing I'd like to add to Fabio's comment, and I didn't include the slide because I was very cognizant of the time, when you look at the overall survival subgroups, the survival for the non-viral group, which as Fabio pointed out was not just NASH, because that's hard to capture in a study, but the survival in the non-viral group was 19 months. The thing is, in the sorafenib group, survival was also 18 months. And the study was randomized 2 to 1, or 2 to 1, so that was 100 patients with atezobev versus 50 with sorafenib. I don't think anyone expects sorafenib to provide a survival of 18 months, right? And that's the problem when looking at subgroups. They're not powered to look at these questions. So it's not that atezobev didn't provide the same survival in the non-viral patients, it's that sorafenib had an unusually long survival. And it's probably an artifact of 50 patients, which made the hazard ratio closer to 1. I see Thomas there as well, all my friends.
I think both the speakers have put their point of view very clearly. So I would like to have opinion of the House. How many in favor of TKI?
A show of hands, please.
Okay, Dr. Acharya.
I didn't see it. Could someone tell me the vote? Was it?
The majority of the House was in favor of TKI after.
That's a cost-driven discussion.
I'm sorry. I will address both speakers. You see, all the registration trials, and if you see different real-life scenario, are giving different results, and you are trying to debate them. And by now we know the cirrhotic with HCC are a heterogeneous group. By also, amongst the child, say, A5, they can be divided according to the ILBS scores. And it is also known, according to ILBS scores, the results of all these therapies are different. None of the registration trial had taken or randomized them according to the biological aggression of the tumor. And hence, the different result. That's the most important thing when you randomize today, knowing that you have a biological aggressiveness, cirrhosis is heterogeneous, the tumor is also heterogeneous. These two basic heterogeneity has not been addressed in any of the registration trial, despite your arguments. However, the immune checkpoint inhibitors are improvement over the TKI, and the combination therapy probably will give us to take away this heterogeneous fact. I would like Fabio and others to comment on this.
In the interest of time, I would like to thank both the speakers. I'm sorry we are not able to take any more questions. We can probably have more discussion over.
Sorry, Richard.
No worries, no worries. Thank you for having me. Everybody stay well. Difficult week for all of us.
Thank you, Dr. Finn.
So, it is my pleasure to invite the next speaker. The topic for the next talk is combination therapy for advanced HCC, BCLC-C, with locoregional immune checkpoint inhibitors and tyrosine kinase inhibitors, which and how. The speaker would be Dr. Thomas Yao, who is a consultant medical oncologist at Queen Mary Hospital, Department of Medicine, and Lika Shing Faculty of Medicine at the University of Hong Kong.
So, first I have to thank the organizer for inviting me to talk about combination therapy for advanced HCC patient. So my focus will be mainly talking about combination with with immune checkpoint inhibitor and TKI. There's not much data about combination with local regional therapy. So this is my disclosures. So when you're talking about the combination, I think a lot of combination nowadays is just around the combination with the VEGF inhibitor, whether it is antibody or the VEGF small molecule with the checkpoint inhibitor. So why we do that? Because potentially when we combine the checkpoint inhibitor with the VEGF, we can potentially make a cold tumor to hot tumor. So basically, nowadays, we only use the immunotherapy in the hot tumor. When we use immunotherapy in the cold tumor, the response is less optimal. So the idea is if we combine with the VEGF inhibitor, we can turn a cold tumor to a hot tumor, and the patient can have a very good response. At the same time, the use of the VEGF inhibitor may have some effect in the tumor microenvironment, especially it can have some effect in the T regulatory cell and also the MDSC in the tumor microenvironment. It enables the tumor microenvironment become immunopermissive. So I think you just hear about Richard Finn's talk. So all of you remember atezobev in hepatocellular carcinoma, and now it is one of the well-standard and widely used. So just to recap, it is a first-line clinical trial. So what basically Richard Finn says is true. In this clinical trial, they recruit a lot of high-risk patients, include the VP4, VP5 patients, and then in this clinical trial, 2/3 of the patients received the atezobev as such, and then another 1/3 of the patients received sorafenib. So this updated analysis just show you the median OS and median PFS of this combination. You can see for the median PFS, the patient on atezobev actually has a much better than the patient on sorafenib. For the update median OS, nowadays I think atezobev, the median survival is more than 20 months. You can see, okay, for patients with advanced hepatocellular carcinoma with survival more than 20 months is actually not easy. Also, majority of the time, although we use 2 agents versus sorafenib 1 agent, however, the patient on atezobev, they are relatively well tolerated. Majority of the grade 3/4 toxicity we are talking about is mainly the hypertensions. So apart from the atezobev, we also published the combination of the atezo with a small TKI cabozantinib, which was in the phase 3 Cosmic 312 trial, which was published in Lancet Oncology last year. It was, again, a first-line clinical trial. We randomized patients into 3 arms. One arm of the patient received cabozantinib, another arm of the patient received sorafenib, and then third arm of the patient received the cabozantinib plus atezo, with the PFS and also the OS as the dual endpoint. So if you look at first the primary endpoint of PFS, you can see the patient on the cabozantinib plus atezo, at all time points, they have a better PFS than the patient on sorafenib with the hazard ratio 0.63. It is clearly equal to the atezobev. However, when you look at the OS, interestingly, if you look at the interim and final OS, the patient on the combination, they actually have very similar OS to sorafenib patient. So if you ask me why, I would say, I don't know. Some people may suggest actually the cabozantinib have some hepatotoxicity. Some of the patients actually discontinue cabozantinib early. So it accounts for the patient may have a PFS benefit but cannot have eventual OS benefit. So how about the treatment-related toxicity? As well, I say the combination is not easy to take in. Nearly half of the patients experience some grade 3-4 toxicity, mainly in terms of the diarrhea, harmful skin reaction, and also some of the patients have a quite significant liver toxicity compared to sorafenib. Another very important study to mention about the combination is the combination of the Lenvima together with immunotherapy pembo. This study, before we know the final result, a lot of people think it must be a positive study. It is similar to the ATISO study. It randomized patient with a histologically confirmed CC, no past systemic treatment, and then 1-to-1 ratio. Half of the patient received the combination, another half of the patient just received Lenvima. Unfortunately, the primary endpoint, OS, did not show significant improvement. You can see the hazard ratio for this study is actually 0.84. The patient, the two survival curves overlap with each other until around 40 months of follow-up. And then, if you look at the treatment-related toxicity, the patient on the combination is actually quite well tolerated compared to the nivolumab, Lenvima. You can see majority of the treatment-related toxicity are related to the Lenvima. Most of the time, the combination toxicity is only hypertension, diarrhea, and some of the patients may have transient thyroid dysfunction. So another important target to mention is the combination of IO, especially the use of the anti-CTLA-4 in combined with the anti-PD-1. So the concept is if we use the anti-CTLA-4, it can potentially increase the activation of the T cell in the lymphoid educating organ. And then eventually more activated and mature T cell can travel through the bloodstream to the tumor microenvironment. It can work synergistic with the anti-PD-1. And also recently, people find that anti-CTLA-4 can actually have some inhibitory effect on the T regulatory cell in the tumor microenvironment. So what is the evidence? So this is one of the important studies led by me called CheckMate 040, cohort 4. It actually is a early phase 1-2 study. It has 3 arms. One arm of the patient used high-dose ipilimumab, another arm of the patient used normal-dose ipilimumab, another arm of the patient used continuous lethal EP. You can see the waterfall plot here. The patient who actually used the high-dose ipilimumab, a lot of patients have a significant tumor shrinkage. 8% of the patients enrolled in this clinical trial have complete remission compared to the patient who actually used the normal dose ipilimumab. The high dose arm is better. Even if you look at the patient who actually developed a progression on high dose ipilimumab, you can see their progression is just slightly compared to the normal dose and the continuous. So if you look at the survival according to the response, you can see if the patient responds to the high-dose ipilimumab, basically this patient is a long-term survivor. They basically won't die. If the patient have a stable disease, they actually still have a better survival than the patient actually didn't respond. So the patient didn't respond, they just follow the normal history of HCC. So the toxicity here is clearly the high-dose ipilimumab will result in more skin toxicity, and more patients have a transient liver function derangement, and more patients may have thyroid function. And the grade 3-4 toxicity occur in around 50% of the patients. Also, you are going to hear the human layer study, which is a phase 3 study. It has 4 arms initially and subsequently reduced into 3 arms. So Himalaya study showed that the use of the high-dose tremipastera actually result in a significant improvement in overall survival with hazard ratio 0.78. You can see initially the two curves overlap with each other with longer follow-up. The patient are actually on the high-dose chemi, they become a long-term survivor. And then finally, about the combination, we also have tried the IO combination with TKI. So this study was just published in Journal of Clinical Oncology this year. Basically, we use this triple combination in patients with advanced hepatocellular carcinoma, and then it is a phase 1-2 study. We recruit around 60 patients in this cohort. So if you can see, if you look at the right side, the orange curve is the waterfall plot curve for the patient receive the triple therapy. You can see a lot of patients have a quite dramatic tumor response. Even the patient have tumor progression, they only have quite slight tumor progressions. So finally, about the combination with the local regional therapy, I don't have any mature data to show you. However, there is a lot of ongoing phase 3 study has completed, like the Emerald one, which combined the BEV together with DERA and TACE versus TACE, and the LEAP-12, which combined the TACE, Lenvima, Pembo versus TACE. And also, there are other phase 1-2 neoadjuvant HCC trial going on, like the use of the double IO, IP plus LIVO, and also the use of the LIVO plus other inhibitor. Thank you.
Thank you, Dr. Thomas. And I think paucity of time will not allow us to take many questions. We can take up at least one question from the house in case it's there. If none, then thank you, Dr.
Thank you.
And I'll invite Dr. Robert Gish, who is Chief of Division of Gastroenterology and Hepatology, Loma Linda University, California, and he will be speaking on newer anti-cancer drug for HCC. Over to Dr. Robert Gish.
I think we need audio for this.
This is Dr. Gish. You had a recording, but if that's not working, I can also provide a live discussion. Please let me know.
Is the recording not working? Okay. Okay, so Dr. Gish, we don't have a working recording right now. So if you can possibly present your PPT, that would be great.
Great. I know I have 12 minutes, and I'm really glad I listened to the rest of the presentation, so I'm going to customize to the previous lecture. So this is very helpful. And if they'll allow me to share screen, hang on just 1 second. I got to make sure I have the correct slides up. Hang on 1 moment. Yep, here we go. Let's go to share screen. Okay. Here we go. Thank you very much for having me. I'm going to be talking about liver cancer management, newer agents, but I'm actually going to be giving, I think, a perspective on the previous presentation. I'm going to focus quite a bit on the new BCLC staging and treatment strategy with the 2022 updates. I want to highlight that AST and ALT are not liver function tests. These are liver enzymes. I really want to encourage the participants and audience to transition to this new terminology. I agree with one of the previous speakers that the ILBS score, which is an assessment of liver function, is a very accurate way of staging our patients, simpler and potentially better than the MELD score. It's really important to be thinking about ECOG for all of our patients, of course, and I'm going to be talking about this BCLC staging and stage migration, both progression and regression of disease. So I think these are really important as we're talking about new agents. This is the ECLC staging strategy in 2022. A lot of information on this slide, so I'm going to move quickly forward and talk about subgroups, of course. And we're going to be talking here both about assessing patients with a Child-Pugh score, ILBS score, and as you know, the MELD score has been updated to MELD 3.0, mostly taking into account gender issues, so trying to minimize diversity in organ allocation, but I also think this takes into account a better staging of patients with more accurate assessment of renal function. This intermediate stage is super important because this is where we're thinking about systemic therapy. I agree with Dr. Finn, we're really looking at a 2-year or better median overall survival, starting with our first-line therapy, but instituting second and third line therapy. And where we don't have access to IO therapy, either AB therapy or DT therapy, TKIs still remain a dominant option for our patients, especially based on cost issues that are present. I also agree with our previous speaker, Dr. Yao, that we don't have sufficient information about ablative therapy combined with either TKI or checkpoint inhibitor therapy. So we're really waiting for these new trials, which are properly designed with large patient population. Once we get into advanced stage therapy, even though sorafenib is no longer first-line therapy, I still think it's co-first-line therapy for patients who don't have the financial means to support AB or DT therapy, or those who cannot come to infusion centers or may have other contraindications such as autoimmune disease or substantial portal hypertension. I think it's very important to be staging our patients correctly, of course, with a multi-phase MR scan or 4-phase CT scan and using LIRADS criteria. I want to highlight here as you're thinking about the newer therapies, what is happening with treatment stage migration. This can occur in response to first-line therapy. Stage migration can mean progression or regression of disease, so it's very important to be thinking about our patients moving through therapy and what's happening as we restage patients. Some of the guidelines I've read recently have talked about doing reassessment at 4 weeks after a given intervention, but I think we really need to stick with a 3-month cycle, both with ablation or systemic therapy. That allows us to have a full assessment about treatment response or non-response. This radiologic progression is highlighted here, such as a growth of 20% or greater in existing nodules or new intrahepatic lesions. I think it's very important also to be thinking about these subgroups that are highlighted here, including the B, C1, and C2 category. I also want you to be thinking about this multidisciplinary tumor board as you think about new agents coming online, being evidence-based. I think real-world data, as Dr. Finn highlighted, is very important for safety purposes, but it's really these randomized controlled trials, phase 3 studies that really give us the evidence on what our choices should be for our patients. I agree that an alpha-fetoprotein is a relevant prognostic factor. You can be using 400, 500, or 1,000 as a cutoff. I think the ILBS score is extremely relevant to our patients, especially in the HCC setting, although it's been used in other settings as well. Adding Y90 radioembolization for tumors in combination with checkpoint inhibitors is also being looked at and also with TACE therapy. I'm going to talk very briefly about these checkpoint studies and give some new perspectives in the few moments that I have left. You've heard very, very good data from Dr. Yao, from Dr. Finn on these, but I think it's very important to be thinking about treating the underlying disease. One of the problems with the studies, including the IM-BRAVE study, is a lack of homogeneity in terms of managing hepatitis B, hepatitis C, alcohol-related liver disease, or fatty liver disease. So as you look at new data emerging with some of the new agents, it's really important to be thinking about, did the studies control for hepatitis B, C, fatty liver, or alcohol management? In my experience, the great majority of patients with non-viral induced HCC is fatty liver disease, whether you use MAFLD, MASLD, or any of the other new terms that are present. Progression-free survival is important to be thinking about, as well as overall survival. But I want to talk about quality of life. QOL is something that's very important. I believe that the A, B, and DT therapies provide much better quality of life for my patients. I have a great majority have minimal or no side effects. Of course, a subset are at risk for bleeding, as you heard, especially with VP4, and also issues such as autoimmune disease if there's an underlying autoimmune history in a given patient. Same thing with the Himalaya trial, although the survival is slightly less than you saw with the AB therapy. I do think that DT therapy may have a role in managing patients with HCC with fatty liver disease. This needs to be teased out in future studies, and looking at subgroup analysis, as Dr. Finn said, is a definite challenge. A little bit more data here that you've already seen in terms of overall survival and looking at durvalumab versus sorafenib as well. So you heard some important issues about that. This is a really important, I do like these forest plots in terms of giving information across different groups. I want to highlight one important issue on this slide, which is hepatitis C. There's been incredible heterogeneity in terms of treating hepatitis C in patients with HCC. 2 papers published in around 2017 gave a hint that treating hepatitis C made liver cancer worse. I strongly disagree with that proposition, and I think the subsequent 7 papers published since that time have shown that treating hepatitis C improves renal function, liver function, decreasing portal hypertension, and I think it's very important to be managing hepatitis C immediately at the time that HCC is managed. It's very important to be thinking about this child's A5, A6, and then of course B7. We do have data with TKI inhibitors in child's B patients, as well as nivolumab. I think these are options for our patients with mildly more advanced disease. You've already heard about what the choices are for first-line therapy. You heard a vote from the audience about TKI inhibitors. This can be a financial decision on a global basis, and I think that's a very important to take place. A few other studies that are emerging right now is camaralizumab with rivaroxabanib. So I think this is very interesting in terms of active disease, in terms of median overall survival. You heard a little bit of data also about pembrolizumab, which did not, in my opinion, did not reach that primary endpoint. People who respond do better. Of course, this is sort of a natural issue. But if people have initial response to therapy, I think we need to be more aggressive about second and third line therapy in those patients. This Louch trial has given us a hint that lenvatinib plus TACE may do better. We're waiting for further information on this in terms of a phase 3 study. I want to thank you for having me here, and just extremely excited about systemic therapy for our patients. I'm involved with tumor boards across California and Nevada. I'm actively managing 50 to 60 liver cancer patients at a given time. I'm extremely impressed with the safety profile of AB therapy as well as DT therapy. I have had a few patients with severe autoimmune reactions, but the great majority of patients tolerate this therapy very well. I think we have data that's limited in Child-Pugh B7 and B8, but I do offer these patients this therapy in a controlled setting. Of course, managing portal hypertension with banding, and of course, Carvedilol over Enderol. We also use statin therapy in my patients, although we need further information there. I want to thank you very much for having me. The previous speakers did a great job. I hope I did an overlay on this. And we do have over 500 trials on liver cancer going on anytime globally. That's available through the NIH and FDA.gov if you want to be interested in more of those. I'm ready for a Q&A if we have a few moments.
Wonderful talk. We would like to have comments from our panel. And maybe one question from the house, because of short of time.
Yeah, we have had an excellent series of lectures. And the most important thing is that we have to factor in one more thing in a region like this, that is the economics of treatment. So that needs to be also addressed. In this, the neo-oral medications are, I think, more preferable for this region. With this, I think we can have questions now.
Yeah, if there's no question, I think probably we can close this session. Thank you, sirs.
Thank you all. Hope to see you next year in person.
Thank you, everyone. All of you can assemble for a group photograph. Once again, we request the speakers to be, please stick to the time, and the chairpersons to please ensure that. And now we begin with the next session.
Hello everyone. Now we are going to start with the state of art lecture. So the chairpersons for the current session are Dr. Hanuman Yadav, Professor in Radiation Oncology, ILBS. Dr. B.R. Mehdi, Department of Gastroenterology and Hepatology, PM Healthcare, Shillong. We are very pleased to introduce the speaker of the session, Dr. Chandan Guha. Dr. Guha is a professor in Department of Radiation Oncology, Montefiore Medical College, Albert Einstein College of Medicine, New York. So please.
How many minutes? No. You will.
We will give you the time outside. We have two more chairpersons with us, Dr. Harshad Devrabhavi, Professor in Gastroenterology at St. John's College and Hospital, Bengaluru, and Dr. Anurita Srivastava, Professor of Department of Radiotherapy at M.I.C.E, New Delhi.
So thank you, the organizers and Dr. Sareen. ILBS has been my home away from home, and I really, really appreciate every time I visit. For the lack of time and all the discussion which went by for immune checkpoint, I want to give the take-home message for what I'm going to talk about. Immune checkpoints are like driving cars without brakes. At the end of the day, whatever you have before you started, those T cells are the ones which will react. What I'm going to talk about is that for the cancer to spread and progress, they had to evade the immune system. So the T cells which were present to do immune surveillance, they are the ones which immune checkpoint will be kind of increasing. And what we will make a case of immune priming or primary immunization, which should be the foundation on which immune checkpoints might work. So that's one step. The second step is we are talking about systemic therapy with survival as the endpoint. In some situations, loco-regional therapy might be beneficial. The NRG RTOG trial will hopefully soon be published, and there is an embargo, so I cannot give the results away. But under the right pair of hands, how scalpel becomes a surgeon's art, likewise, X-rays or radiation in the right pair of hands become an art which improves survival. So our goal is focal therapy for systemic cure. And I would like this message that if we ever branded radiation therapy as an immunomodulatory drug, and for the sake of operations, divide it into 3 types of immunomodulation. One, which is very ablative, where there is 90% local control of the tumor, and therefore the tumor is expressing or releasing, dying tumor cells are releasing antigens, mutated proteins, and damage-associated signals for antigen-presenting cell activation. So that's the ablative group. Then there is this somewhere in between immunomodulatory group, where maybe you are not able to control the tumor, but you make the tumor vulnerable to immune attack. And finally, there is a very, very low dose radiation which helps tumor modulation, tumor microenvironment modulation. And this might be very helpful for things like CAR T cell and adoptive cell therapy. These are my conflicts. Mostly they are NIH grants, but I'm also a co-founder of a bioconvergent health, which combines device, drug, and cell-based therapy. So I don't want to go over the tumor immunity cycle, but you can more or less modify that from radiation point of view, that like driving a car without gasoline, the car will not run. Without tumor antigens, new T cells will not come. And the idea for us is that is there a way by which you can release tumor antigens to primary immunize the various mutated progression which the tumor has experienced during its life cycle. But the important thing I would like to stress, especially for the context of liver, that while the tumor immunity cycle is a generalized way of thinking, but there is also an organ-specific microenvironment. And for liver, it's usually a tolerogenic signal which we have to look at. So with that, very quickly, I would like to summarize some of the trials which have combined radiation with immunomodulation. So one group is the standard 6-week to 8-week radiation for locally advanced cancers, not metastatic, where mostly after chemoradiation, if you do adjuvant immune checkpoint, there was improvement in survival. So that's the classic is the Pacific study for lung. Contrast to that, in head and neck, where concurrent immune checkpoints were used with chemoradiation, the trial became just the opposite. In fact, if you look at it, this is one of the few studies where the immunotherapy arm probably did more harm than good. And this could be understood by a classic paper which showed that while it is true that radiation can activate T cells, but if you now invite the T cells to the party and kill with your next cycle of radiation, then what's the benefit? Next are a group of trials with metastatic patients where, for good or bad, instead of doing standard phase 1 studies of different doses of radiation, people chose to take the middle dose, 8 gray times 3, and most of these studies have not shown abscopal effect, which was the endpoint. And I think both of these are not right. We shouldn't take abscopal effects as endpoints. We should keep survival as an endpoint. And the criticism in an editorial in JCO that whether abscopal effect is an urban myth, I believe it. So who cares about an abscopal effect without a survival? However, the same trials in a neoadjuvant setting before surgery, giving 8 gray times 3 plus immune checkpoint, both in the trial here shown in non-small cell lung cancer by Sylvia Formenti and Cornell group, and head and neck showed an improvement, like you see here, that immunotherapy alone had a complete pathologic response in 0 versus about 25% in the radiation plus immune checkpoints. So with that in background, I'm going to make a case that it is antigen presentation which is most important. Today, talk about mutations. Mutations may be good in some cases. For example, the KRAS G12D mutation in pancreatic cancer helps pancreatic cancer cells, pancreas to heal properly in case of chronic pancreatitis. As far as the immune system is concerned, it is geared to look at strangers and dangers. And what I'm going to make a case is that as the tumors progress, and there are passenger mutations and oncogenic mutations, these mutated proteins, how can I train the body to recognize them as strangers or dangers? So with that in mind, in the 90s, our group worked on a concept that if you give a large dose of radiation in a metastatic murine model, is it possible that antigen presentation using dendritic cells or using professional antigen presenting cells would be beneficial? And to do that, we took a product called a cytokine called FLT3 ligand, and you will hear more about it. But these dendritic cells are the professional cleaners. They come, clean up the house, and then migrate like photojournalists to the lymph nodes where T cells are sitting there, and to educate these T cells so that they can now go and try to eradicate cancer elsewhere in the body. And mostly radiation for me is all about viral mimicry. The double-strand DNA breaks which radiation causes is essentially allows the body to think as if they have a viral infection. And so I wanted to see that in a metastatic model of lung cancer, if I cure one site and then give these dendritic cells to come with a relative dendritic cytosis in the blood, can they eradicate lung mets? And the answer here is absolutely. In these models, about 50% after radiation plus FLT3 ligand were cured. In contrast, surgery, which also had 100% tumor control, did not cure anybody because the antigens were gone. If you do the same experiment in an immunodeficient mice, the effects went away. And the reason is, while the radiated animals had lung metastasis, the radiation plus FLT3 ligand did not have lung metastasis. So one thing we realized subsequently, that even though people showed abscopal effect with low doses of radiation, if you look at the survival, even though the title of this paper looks great, but look at the survival curve, half dose, killing a tumor halfway is not going to help in the process of antigen presentation. So subsequently, we underwent a trial with a company called Celldex using CDX301. The goal was that you treat one site in a lung cancer and see the effect. So these were all 29 subjects were enrolled in this phase 1-2 trial. 26 out of 29 failed PD-1 or immune checkpoint to come in the study. 3 were not eligible for immune checkpoints. And if you look at the study, Monday to Friday, 5 fractions or 3 fractions or even one single fraction of radiation was given, all from RTOG trials. And during that week, subcutaneous dose of FLT3 ligand was given in these patients. Look at the adverse events. There is 0 grade 3 toxicity, so it's highly tolerable. But more importantly, what we realized is a metabolic PET scan for the unradiated sites at 2 months was highly significant to correlate with overall survival. This shows a spider plot, which essentially shows that, the patients who had a response, even though they had immune checkpoint failure, they had a huge response, and 9 out of 29, almost 1/3 of the patients had an abscopal effect, and that resulted in overall survival. These are some of the examples where you had a large lesion in the right lung, and you could treat the metastatic site with one single fraction, and over time, almost 3 years, this patient had no systemic therapy, and yet they were free of disease. There were examples of pleural mets and so forth. So overall, what I'm going to summarize is that there is a case of antigen presentation as an immune response, and that's where we would like to see whether the liver HCC group can go into such a story. So I stop here and take any questions you may have. Thank you.
Dr. Guha, thank you very much for that comprehensive lecture. As this is a state-of-the-art lecture, we will not have any questions. Thank you.
Hello everyone. Now let's begin with the 10th session, that is immune therapy for HCC. I would like to introduce the chairpersons for the session. Dr. Ramesh Roop Rai, Department of Gastroenterology, Rai Specialty Care and Research Center, Jaipur. Dr. Taran Gupta, Professor, Department of Hepatology, PGIMS, Rohtak. Dr. Sunil, Consultant, Gastroenterology at SNMC, Jodhpur. Dr. Shahinul Alam, Professor, Department of Hepatology, PSM Medical University, Dhaka, Bangladesh.
This session will be moderated by Dr. Govind Makharia, Department of Gastroenterology, AIIMS, New Delhi. Dr. Deepak Lahoti, Gastroenterology and Hepatology at M.I.C.E Specialty Hospital, New Delhi. Dr. Praveen Rathi, Gastroenterology and Hepatology at Bombay Hospital and Medical Research Center. Dr. Sudhir Maharshi, Associate Professor, Department of Gastroenterology, SMS Hospital, Jaipur. I would like them to take their seats and introduce the speakers.
Hello, good morning. So we start with the next session 10, immune therapy for SCC. We all know the basis of current treatment of SCC depends upon the tumor microenvironment. So we'll have the first talk on immune microenvironment, trajectory of immune evolution of SCC, and the implication of this in immune therapy. I invite Dr. Jean Charles Nord for this lecture.
Thank you very much for the introduction. So this is my conflict of interest, and I will talk in the first of the role of immune system in liver carcinogenesis to give a background, and in the second part, the biomarker of response to immunotherapy. So what about the role of immune system in liver carcinogenesis? It is well known that there is a balance when you talk about immune system between the role of immune system and chronic inflammation in occurrence of chronic liver disease, cirrhosis, and HCC, and on the other side, the role of immune system with the anti-tumor immune response. So first, there is a preclinical model showing that obesity and induced chronic liver disease and liver inflammation. It is a mice model with DEN in obese mice showing that there is activation of JAK-STAT pathway, liver inflammation, and HCC development in this model. And when you knock out IL-6, that is the ligand of the ILC JAK-STAT pathway, is decrease the liver inflammation and HCC development, suggesting that tumorigenesis is dependent of activation of inflammatory pathway, at least in preclinical model. And there is a strong role of the etiology, and here it is a model of transgenic MI.C.E oncogene in mice with a model of NASH that leads to HCC development, you can see here, and that leads to necrosis of hepatocyte, release of acid linoleic, and the CD4 T lymphocyte death via apoptosis. So first, chronic inflammation could lead to chronic liver disease and HCC development, but also there is impaired tumor surveillance due to the etiology, and here is through CD4 T lymphocyte decrease activity. So it is a balance between the role of immunity and in chronic liver disease and in tumor surveillance. And recently, a very interesting paper from the Team Gretup group studies the role of mate cell, that is innate-like T cell subtype present in the human liver. And first, they show that there is a decreased mate infiltration in the tumors due to the TAM, tumor-associated macrophage, that induce mate cell dysfunction. And in contrast, when you use anti-PD-L1 inhibitor, that leads to an increased mate infiltration in the tumor, and they suggest that one of the ways how anti-PD-L1 inhibitor act is to reactivate mate cells that reinfiltrate in the tumor and lead to HCC decrease in size. For sure, it's a preclinical model, and we don't know in human what is the true effect of anti-PD-L and PD-L1 in the tumor. So when we come back in human HCC, this is human HCC, you could divide it according to transcriptome and immunome analysis, HCC in different subclasses according to the type of inflammatory and immune infiltrate. First, there is around 60% of HCC with low inflammatory infiltrate, and with enrichment in activating mutation of CTN and B1 that code for beta-catenin, and I will come back to beta-catenin for a biomarker of response to immunotherapy. And a second subgroup, HCC was a strong inflammatory infiltrate that Joseph Lovett called active immune, with enrichment in genes of adaptive immunity and interferon pathway, and that is suggestive to be maybe predictive of response to immunotherapy, and I will come back. But when you talk about immune infiltrate, it's not only hot and cold, because you can have also immune infiltrate, but with defective immune cells. And there is a group of HCC with exhausted immune cells, with enrichment of genes involved in immunosuppression and inhibition of NK cells. So it's not black and white, and you can have immune infiltrate but are defective or lead to immunosuppression. So what about of biomarker of response to immunotherapy? As you know, there is two main checkpoint inhibitor, PD-1, PD-L1 inhibitor antibody, and CTLA-4 antibody that have been developed for HCC. There is other immunotherapy, such as anti-LAG-3, that are currently tested. And PD-1 and PD-L1 and CTLA-4 leads to escape of the tumor from immune surveillance, and the idea of immune checkpoint inhibitor is to re-increase the immune surveillance and the effect of immune system on HCC. And this is the main first line, antibody, anti-PD-L1, anti-FGF, and antibody, anti-PD-L1, and anti-CTLA-4. So what about biomarker of response? I will talk briefly of what don't work and what maybe work, because there is no biomarker of response used in clinical practice. First, it is a PD-L1, PD-L1 inhibitors. PD-L1 is a ligand produced by the tumor to inhibit the lymphocyte. So the question is PD-L1 expression in the tumors could maybe predict response to immunotherapy. However, it is not the cases. As you can see, there is response also, a little bit less, but still response, 90% in tumors without any expression of PD-L1 on the expansion phase of the phase 2 published in Lancet. So PD-L1 expression is not a good predictor of response to immunotherapy, first point. Second point, mutational burden. So it is known in other type of cancer that when you have a high rate of mutation, you have a high rate of neo-antigen due to this mutation that stimulates the immune system, and that is predictive of response to immunotherapy in some cancer, like colorectal cancer, melanoma, and lung cancer. More mutation you have in the tumor, more response you have to immunotherapy. However, there is a drawback in HCC, because HCC are rarely hypermutated. It is medium-low rate of mutation, and the only subgroup of HCC with a high rate of mutation is aflatoxin B1 related HCC, that is a mycotoxin that contaminates culture in Africa, and I'm not sure that Big Pharma wants to run a trial in aflatoxin B1 related HCC in Africa. So mutational burden, not a good biomarker. So Matthias Ankenwalder and Joseph Lovett suggest first on a preclinical model that NAFLD in mice, induced in mice, could lead to a resistance to immunotherapy. And analysis of subgroup analysis in patients show that there is a decrease of overall survival in NAFLD patients treated by immunotherapy. It's maybe due to an aberrant T-cell activation causing tissue damage that leads to impaired immune surveillance. It's a theory, mainly in preclinical model. However, this is a recent meta-analysis by Tim Meyer and Han Vogel of 8 randomized control trials in immunotherapy in HCC and non-viral liver disease, non-viral NAFLD maybe, with a little bit of alcohol. And they showed that even in non-viral etiology, there is a benefit to immunotherapy in this randomized control trial. So etiology, I think, not a good biomarker. So we could have molecular signature of immune infiltrate, and this is the analysis of mRNA, transcriptome, and this is a proposal by the group of Joseph Lovett suggesting that there is interferon gamma molecular signatures in patients predictive to response to immunotherapy, but only a small cohort of patients, 30, and retrospective. So not robust enough. And there is another controversy. I told you that beta-catenin HCC have a low immune infiltrate. Preclinical models show that beta-catenin mutation was associated with no response to immunotherapy, and a retrospective study in human with HCC suggests that sorafenib there is no difference beta-catenin mutated versus beta-catenin non-mutated for sorafenib, and a worse survival in beta-catenin mutated HCC using immunotherapy. However, it was retrospective study, and the analysis of the phase 1 and phase 3 trial of atezolizumab and bevacizumab show that there is a difference between beta-catenin mutation in terms of survival, but still a benefit in blue for atezo-beva, and maybe a beta-catenin mutation was associated with a better survival in sorafenib. And they also identified a subgroup of tumor with a higher rate of radiological response with a T effector signature and high intratumor CD8 T cell density. But only a small percentage of the phase 3 clinical trial was analyzed, and it was not externally validated. And based on the analysis of this trial, Julien Calderaro in France developed an artificial intelligence analysis based on slides, FFPE slides, to predict these signatures. And so you put slide on the artificial intelligence model that predicts the signatures, the 10 genes signature derived from the Zhu paper in Nature Medicine, and it's predict progression-free survival based on artificial intelligence and FFPE slides, avoiding molecular signature analysis. And to finish, a way to monitor the effect of immunotherapies to analyze circulating tumor DNA, that is small piece of DNA released in the blood by the tumor, and you can sequence the blood of the tumor to identify this mutation. And Claudia Company in the lab done the analysis of patients treated by first-line systemic treatment, and we identified genes mutated, TP53, beta-catenin, and TERT in the blood of patients treated by systemic therapy. 60% of patients have a mutation in the blood, and when the mutation disappeared in the blood under the first-line treatment by atezolizumab, it was associated with a response and stability. And in contrast, when the mutation persists in the plasma, it is associated with progression. So it's a way to monitor early, based on the blood analysis, the response or not of atezolizumab. And just to conclude, the last example, it's a patient treated in a clinical trial by neoadjuvant nivolumab, electroporation, adjuvant nivolumab, and you can see the mutation that appears in the blood of the patient under adjuvant nivolumab, TERT mutation, TP53 mutation, the same mutation observed in the biopsy. And here you can see that there is a new mutation that appears in the blood, mutation of beta-catenin, suggesting that immunotherapy selects subclone that could be detected in the blood of the patient. So in conclusion, inflammation and immune system play a complex role during tumor initiation and progression, with both an anti-tumor and pro-tumor action. There is a role of mast cell in liver carcinogenesis, evolution of tumor microenvironment under immunotherapy, and currently no biomarker of response that could be used in clinical practice. And thank you for your attention.
Thank you. Thank you, Dr. Charles, for a very nice, elaboration on the subject. So what is your practical recommendation? Do you still advise to go for a biomarker testing before starting immunotherapy, or you just start?
No, I think currently there is no biomarker that is currently validated. What we can see is that when you have a high alpha-fetoprotein, when alpha-fetoprotein decrease under treatment, is better survival, but it seems very obvious. So currently it's a matter of research and translational research that cannot be used in clinical practice.
So what do you think, what would the future would be like, the tissue or the liquid biopsy?
Liquid biopsy, tissue, imaging, a classical approach, artificial intelligence altogether.
Yes, Professor Serene.
An excellent talk. I have one query that you showed the mate cell, the mucosa associated invariant T cells. They are increased after immune checkpoint inhibitors. Is that correct?
Yeah, in the tumor, yeah.
So how do you study the replica of mate cells in the peripheral blood? Because that's a very important thing.
Yeah, I fully agree. In the paper of Tim Gretton, there is no analysis of the circulating blood. And I have preliminary data showing that mate cells is modified in the blood of the patients and sometimes could decrease under immunotherapy. Maybe they decrease because they go inside the tumor, but it's only a theory. And it's not published, and we have only a small number of patients analyzed circulating blood cell.
Just to give you an idea, we do fecal transplant for alcoholic hepatitis. And we have shown enough that after FMT, the mate cells increase and they go into the alcohol-associated liver disease. Yeah. So I think there may be a future for FMT for tumors and...
It's very interesting what you say, because it's in melanoma there is a trial of immunotherapy with FMT to increase the response to immunotherapy. In HCC, I don't think it is ongoing. I'm not so sure, but it's a very good idea, I think.
Thank you. With this wonderful discussion, we are going to the next topic. I'd like to introduce Professor Dr. George K. Lau, who does not require any introduction. He's working in the Department of Gastroenterology, Humanity and Health Medical Center, Hong Kong, China. He will talk about the first-line systemic therapy for hepatocellular carcinoma, selection of drug, patient, and duration. Over to Professor Lau.
Thank you, Chairman. I didn't know it's my turn already. But first of all, I would like to take this opportunity to thank Professor Sareen for organizing this beautiful meeting in New Delhi, and to see a lot of old friends and also new friends. The topic assigned to me today is first-line systemic therapy for hepatocellular carcinoma, selection of drugs, patients, and the durations are very tough questions. This is my descriptions. Being from China, we used to describe ourselves in the first slide. So we have heard a lot about and sharing the understandings of new molecules and developed along the pathways of hepatocellular carcinomas, resulting in the registrations of a number of agents. But during the discussions, we understand that unlike other cancers, we didn't find any driver mutations. And this has limited our approach to systemic therapy for hepatocellular carcinoma. On the other hand, with the understandings of immune checkpoint inhibitors utilized in other cancer, it has recently been attempted and tried in hepatocellular carcinomas, and we will discuss about its utilizations, the current situations with the use of these immune checkpoint inhibitors. Well, we don't have any systemic therapy until 2008 when sorafenib comes into the picture. This is the phase 3 study, this is SHARP, and also the Asia-Pacific SHARP, which shows that in those patients with unresectable HCC advanced hepatocellular carcinoma, which is our major healthcare burdens, despite all the surveillance programs with the effective antivirals and the vaccinations, we are still seeing an increasing incidence of cancer, of liver hepatocellular carcinoma. And in the clinical practice, one of our problems is over the past 30 years, unfortunately, people still comes in late with hepatocellular carcinomas for various reasons, and I think that Asia-Pacific Association for the Study of Liver should attempt to help the governance to resolve these problems. Having said that, advanced hepatocellular carcinomas is still a major clinical burden for all physicians and involved in the caring of patients with liver diseases. Since sorafenib, it is only until recently we have new molecules made available, which is summarized here as a first-line therapy. Based on the larger phase 3 studies, the REFLEX, IMbrave 150, and in China, the CGD H3 and Orient 32. Resulting in the availability and drugs registered for unresectables or advanced hepatocellular carcinomas as shown here, the lenvatinib, the atezolizumab, the donafenib, sintilimab, and IBI 305. The absolute survival gains is being shown over here of overall survivals, which is lenvatinib is similar to sorafenib. It's a non-inferior test. The overall survival hazard ratio is 0.92. And the IMbrave, the hazard ratios for overall survivals as shown here is 0.66. And then in the China studies with the two compounds is 0.83 and 0.57, which makes them available as a first-line therapy for unresectable HCC. On the other hand, for those patients who has failed the previous sorafenib, we have studies also confirmed in phase 3, large-scale randomized studies as a second-line therapy. As shown and is summarized here in this table and suggested by the resource studies, the Keynote 394, the Celestial studies, the RICH2, and AHELP. This has enabled us to have other agents made available for our patients who have failed and could be considered. Now, one of the important message here being practicing hepatologists in Asia-Pacific regions, seeing, well, in my lifetime, 3 decades of careers, more than maybe 5,000 unresectable HCC. It is really a good news to have new therapy made available. Sorafenib, personally, the experience is not too good. It's improved a little bit of survival and caused a lot of side effects and is very costly. But we have learned from the availability of new target therapies and also ICI. And I think this is very important because in Asia-Pacific regions, most of our hepatocellular carcinomas are related to viral hepatitis, especially B. And this paper stress out the very important points for us to consider. And that is those patients with hepatocellular carcinomas with viral hepatitis, based on a meta-analysis of 8 randomized controlled trials with 3,739 hepatocellular carcinomas conducted between 2002 and 2020 with numerous studies, shows very confidently that patients with viral hepatitis-related hepatocellular carcinomas respond better to immune checkpoint inhibitors therapy. And this point needs to be considered when we want to treat those patients with systemic therapy. So 2023 and beyond, ladies and gentlemen, we have a recent study which has been published in the New England Journal of Medicine Evidence. It's a phase 3 large-scale global studies and making use of dual immune checkpoint inhibitor, the TREMI and durva in unresectable hepatocellular carcinomas. In our studies, which is called the Himalaya studies, Himalaya is part of India, was an open-label, multi-center global phase 3 studies where we randomized unresectable HCCs with stage B or stage C with good liver functions into dual immunotherapy, and that is a strike regimen, a TREMI, high dose, CTLA-4, 300 milligrams for 1 dose, followed by durva, 1,500 milligrams every 4 weeks, compared with durva alone and sorafenib as a first-line therapy. And the primary endpoints were overall survival for strike versus sorafenib, with secondary endpoints of overall survivals, non-inferiority of durva compared with sorafenib, and also we measures the progression-free survivals, ORR, DOR, and safety. The primary objectives was achieved in these studies, and the drugs was approved a couple of months ago for the treatments of unresectable HCC based on these studies, which showed that strike, that is a high-dose CTLA-4 plus PD-L1, results in improved overall survival with the hazard ratios of 0.78. And very importantly, in these studies, we also have long-term follow-ups of 3 years and 4 years, and I will present the data later on in our lunch symposium sponsored by AstraZeneca. Now, with the availability of these phase 3 studies, strike regimens is now registered as a form of therapy acceptable by US FDA, Japan, and EU. And the trade names for TREMI is Imjudo. One of the very important concerns related to the use of immune checkpoint inhibitor, especially is involving CTLA-4 as a component in dual immune therapy, immune checkpoint inhibitors, is the occurrence of side effects. And recently, we have analyzed the data about immune-mediated adverse events in the Himalaya studies. And we have shown that most immune-mediated adverse events with strike or durvas were low-grade, and most occurs within the 3 months of treatment. And I think this is very important when we take these considerations and as an information for the physicians who take care of patients with unresectable HCC and also to the patients and the relatives. And the 4 years overall survivals updates is being here and was presented in the ESMO's a couple of months ago, which shows that 1 out of 4 patients remains alive at 4 years. The 48 months overall survival for strike regimens is 25.2% versus sorafenib at 15.1%. So, in 2023, October, how do we choose the therapy? And this is the topic assigned to me. Frankly, I don't have an answer. Interacting with many centers. I work in Hong Kong, Shanghai, and Beijing. seeing lots of hepatocellular carcinoma and resectables. But these are the considerations, and I would like to open this to the dialogues for considerations. We have numerous guidelines, but these guidelines are being guided, in a sense or not. And then we have to consider the affordability. Well, when the drug is available, whether we can afford this, whether the patients or the healthcare systems can really afford it. And then we have to consider about safety, how to manage the safety, side effects, immune-mediated adverse events. And it also comes into considerations, one of the important components when we want to decide what to use is the clinical experience of the physicians themselves, the centers, the capabilities of taking care of those patients. And I think that in the future, we should really look at the response of the patients. Different patients respond differently. One thing I learned from Professor Mata, which is on the floor for many years, hepatocellular carcinoma is pretty heterogeneous. And even if it is induced by hepatitis C or hepatitis B, but the subcategories need to be understood. So I don't have a straight way to manage those patients. I mentioned about register agents available for first line and also register agents for second line. But these are the considerations that we need to think about and before we can manage our patients. Now, I believe that the way to move forward is really a cohesive collaborations with a multidisciplinary approach, taking those factors into considerations, involving hepatologists, interventional radiologists, liver surgeons, transplant surgeons, pathologists, oncologists, and also molecular biologists, and maybe immunologists. And in my practice, I have a team of different specialty, transplant surgeons, liver surgeons, and other peoples to be involved, because the concept and the management of hepatocellular carcinomas is being evolved rapidly. And I think that in the future there are lots for us to do, but the most important thing is to really get the benefits to the patients. Last but not least, I would like to thank the group, Humanity and Health Clinical Trial Centers, which is part of our Humanity and Health medical group. I'm the chairman of the medical group and the principal investigators for this private clinical trial center, which is the largest in Hong Kong and China. Thank you very much.
Thank you, sir. That was really an exciting and thought-provoking talk. I would like to ask you one thing. You talked about the response-guided management of, when you are using the checkpoint inhibitor. So how the response will be assessed objectively by imaging or by liquid biopsy? Can you just elaborate?
This is a very good question. So I think that the monitoring of the response is pretty different from TKIs and immune checkpoint inhibitors. In the Himalaya study, it's in my center, which recruits the largest number of subjects for the entire phase 3 global study. We maintain the patients on therapy even if there is disease progressions, and we can, by the conventional methods of the RECIST criteria, and they later respond. So the immune therapy somehow does not reflect immediately. And you can see over the survival curve, the tail spread out later on, and not at the very beginning. So in my practice, 8 to 12 weeks assessments on the alpha fetoproteins, on the imaging, either CT scan or MRI. Unless they have a convincing evidence of disease progressions, then I would switch to other therapy. But having said that, with the availability of the strike, and if the patients can tolerate, I have patients who actually have a strike again with the CTLA-4 again, if it is tolerable and affordable, and they did respond. In my practice, I have already got up to date outside the trial 3 patients with complete response from unresectable HCC, and one of them just received liver transplantations. And they have survived up till now more than 4 years. So this is something which I think is a dynamics, and that's why I think we need a multidisciplinary approach and in a sensible manner, because after all, we want to improve the overall survival with quality life for patients with unresectable HCC. This is a very exciting moment. Previously, we didn't see this type of response with those patients at this stage of the disease.
Yes, please.
Excellent talk, Dr. Lau. I am Samaksh from AIIMS, New Delhi. My question is related to the choice of placebo in the first-line trials for unresectable HCC.
Placebo?
Placebo, yeah. So,
we don't use placebo anymore.
So do you think lenvatinib would be a better comparator in those trials compared to sorafenib?
They have a non-inferiority studies as I illustrated. I don't think there is any studies comparing lenvatinib with placebo because we already have a standard of care, and I think this is important. We always compare with the standard of care we have already for new therapy.
So thank you, sir.
Question. Dr. Lau, is a wonderful talk. You name this study as a Himalaya study. Yes. What is the philosophy behind that? Do you think this is the result will be as tall as Himalaya or something else?
Please come to the lunch symposium, and we will discuss about this.
Sure.
Okay. Thank you, sir. Now, it's my pleasure to call Professor Yogesh Chawla. He is Chairman Academics and Professor Emeritus from Kalinga Institute of Medical Sciences, Bhubaneswar, and ex-Director PGI Chandigarh. Sir will take the case scenario.
Thank you very much. We've discussed enough of immune checkpoint inhibitors, and the case which my friend Vishnu is going to present is from ILBS, and there are some interesting points which we will like to discuss. Over to Vishnu.
Good morning, everyone. I'm presenting the case of Mr. J, who was a 60-year-old male who is a diabetic with HbA1c of 9.1 and known hypertensive with maximum weight of 67 kg. He presented in March 2023 with complaints of pain abdomen, and he was incidentally diagnosed as a case of cirrhosis outside, which was HBV related. At that time, his E antigen was negative, anti-E was reactive, the HBV DNA was log 6, his ALT was 32 and his LSM was 75, and HbA1c quantitative was log 3, and he was started on nukes outside. And in May 2023, he developed his first decompensation in the form of acute variceal bleed, and he had post-bleed ascites, and the endoscopy showed grade 2 varices with RCS, and EVL was done outside. After this episode, they've checked the AFP outside, which came as log 2, which was more than 100. And they did an ultrasound again, which was showing a likely HCC with PVT. So he was started on TKI, sorafenib, and he was referred to us. This was his examination finding. On investigation, we found that his hemoglobin was 13.6, TLC was 11,000, platelet was more than 150, was 176. INR was 1.4, his bilirubin was 1.76 with a direct of 0.5, and albumin of 4.3 with AFP of 195 and PIVCA2 of 9,500. His CT showed the arterial enhancement and washout with the VP4 tumor thrombus. So it was in segment 5, 28 into 27 millimeter lesion with the VP4 tumor thrombus. So the working diagnosis was portal hypertension, bleeder, small high-risk varices post-EVL, and CLD HBV related with a DNA of log 6, already started on treatment, decompensated with bleed and post-bleed ascites, and HCC with the VP4 tumor thrombus, with comorbidities of diabetes, hypertension. He was BCLC-C with good performance status, and AFP of log 3 and PIVCA2 of 9,000. This was all. And the first question.
Just be around, please. There are some interesting aspects in this patient. One of them which I thought was the platelet count, although it doesn't classify into thrombocytosis, but this patient of decompensated cirrhosis with HCC with a FibroScan value of 75, having a platelet count of 1.76 is a little unusual, but it may be expected. So what the audience needs to think about is, if the value is very high, thrombocytosis as a paraneoplastic syndrome in a patient with HCC and cirrhosis should be considered. The second interesting aspect in this patient is he's had a bleed 2 weeks before. So what is the therapy that one needs to give to this patient? Liver transplantation with portal thrombectomy is out. One could attempt giving systemic therapy with TKI. His child score is around 7 or 8. One could attempt giving atezolizumab only or A plus B. Since the patient has had a bleed recently, the fourth and the first options are out, and we should not attempt those. One could give TKI or give atezolizumab only, although we don't have enough literature to suggest that atezolizumab is beneficial for this patient. So the chances of bleed in this patient would be high, firstly because he's decompensated, he has portal vein thrombosis, and if you give bevacizumab, there is chances of increased bleeding. Hence, one needs to attempt to do EVL in these patients as often as possible so that you can have non-bandable varices and then give a combination of the two therapies. So after the endotherapy is done and the patient has non-bandable varices, a combination of A plus B would be the best, although one can also think of a systemic therapy with TKI. The best option would be A plus B. So this again is another interesting aspect in this patient. Hepatitis B is there. So should this patient be on nukes, or you can start giving ICI therapy without giving nukes? Literature says that you can safely give the ICI drugs provided the level of HBV DNA is less than 2000. And our patient had a value of log 6. So we were justified in giving the nukes in this patient. So if a person is HBV DNA positive, surface antigen positive, with a value of less than 100 or even 2000, although there are no definitive guidelines on that, one should start these patients on nukes only if the level is more than 100 or 2000 international units. So the further course, Vishnu?
This is where we started, this is where he developed the bleed in June. After that, 2 weeks later, we gave the first dose of only atezolizumab. The repeat endoscopy showed grade 2 esophageal varices without RCS. So the next dose was given a combination of atezolizumab and bevacizumab. And during further follow-up, ascites improved. The varices became eradicated, and his AFP after 3 months had come down from 195 to 151, and PIVCA2 improved from 9,000 to 1,500.
So another interesting aspect is how often do we see active HBV replication in a patient with HCC? Looking at the literature and in our own experience, almost 50 to 60% do not have HBV DNA that is positive. About 30 to 40% of them would have DNA positive. So this is another interesting aspect in this patient. And how do you assess the response? We just discussed, Professor George Lau did make a mention, but literature says that after you have given 2 shots of ICIs over a period of 3 weeks, so that means 3 shots, there should be a more than 75% decrease in alpha-fetoprotein, which probably would guide you that the patient might develop a complete response. But there are no definite guidelines on this. This is just an assessment from 1 or 2 studies that have been published. And lastly, is there a role for giving metformin in this patient who has HCC in addition to metabolic syndrome, diabetes? There is some literature that metformin, although it is chemopreventive, but it also may help in these group of patients, although data is very limited. So friends, I think these were some of the few interesting aspects in this patient which we wanted to discuss, and would be happy to have some comments from the audience.
Thank you, sir. Sir, what about giving SBRT for PVTT and then transplanting this patient? He is relatively maintained. At admission, he is borderline child AB.
So, you know, the SBRT is coming up in a big way for patients with portal vein thrombosis, and so also. He had ascites also. Although, if the ascites would not have been there, SBRT could have been an option, which is much cheaper than TARE. So it's an upcoming, and there's always a little element of radiation-induced hepatitis in these patients.
Sir.
It's very nice, Dr. Chawla. I have just 2 small points. This patient, I think, came after a bleed. But normally I would say we should not do band ligation in patients who have portal vein thrombosis, because there is 60% chance that the patient would fail. So, and we should control this with beta blockers, adequate beta blocker, and then only try and do a band ligation, although there are no guidelines. So, I would like your opinion whether a patient who has not bled for primary prophylaxis, would you do band ligation or would you do a beta blocker therapy?
I think for a person who's not had a bleed, why induce a bleed with EVL? I would personally like to give these patients beta blockers.
And also bevacizumab delays the healing of post-EVL ulcers. So I would say that I will discuss this in the evening, but this is an important point, and I think we should not ban patients even with high-risk varices just because we have to give bevacizumab.
Dr. Yogesh, just a comment. Since this patient recently bled and there is a portal vein thrombosis, so we can also consider bevaci at the lower dosages after control of bleed.
I'm not sure whether a lower dose would prevent a further bleed in this patient. Although I agree this could be a good suggestion, but there is no data to support this.
Okay, thank you.
Thank you, Dr. Chawla, for a very nice case discussion. Now I'll request Dr. Ajay Duseja to present what is new in the literature. He is Professor and Head Department of Hepatology, PGI M.I.E., Chandigarh. Dr. Ajay, please.
Good morning, ladies and gentlemen. At the outset, my sincere thanks to the team ILBS, Professor Sareen, Dr. Ashok, and others for giving me this opportunity. And I'll bring greetings to all of you from PGI Chandigarh. So, you know, Ashok is a dear friend of mine, but then, like few others, he's actually asked me to do this difficult job, you know, what is new when I think a lot of things have been spoken already about, you know, ICI and HCC. So I thought I even asked him that what I'm supposed to do. So, you know, if you look at the literature, it's, you know, full of ICI and HCC, many studies. So I was really wondering, you know, what should I be, you know, covering here? So then I thought that let me see that if you look at the response rate of these ICIs, it's not more than 30%. And maybe another 1/3 would also have maybe adverse events related to ICI. So I was actually thinking that as clinician, and this Dr. Dadich was asking this question, that as clinician, could there be some predictors, and especially the clinical predictors, which could actually help us in deciding about, giving ICIs in patients. The next, if I get some time, because my time has also been shortened to 6 minutes, if I get some time, we'll also talk about the role of ICI, which I thought was for the downstaging and making them fit for liver transplant. So quickly, you all heard, Dr. Nault very well about, various predictors, and, most of these predictors, I think, if you look at these, these are, I would say, what we all call it as, would be beneficial in a preclinical setting. People do talk about, the tumor microenvironment, the PD-L1 expression, and the mutational burden and infiltrating lymphocytes. He did speak about the, the liquid biopsy, circulating DNA, circulating tumor cells. There's a role of gut microbiota, and a lot of studies on, gene alterations which are happening, especially the DNA damage repair and various other gene alterations. So, but then where are the predictors for the clinicians? We need to decide whom to give, systemic therapy. So what do you do? So what I thought, and then again searched the literature, and I found some of these clinical predictors which could be applied maybe in day-to-day, but then we do have experts here, we can have their opinion whether these are of some value or not. The first thing which has again been discussed about the etiology of HCC, viral versus non-viral. I personally feel that the jury is still out. We don't know. It's maybe a little inconclusive, but then maybe we'll discuss on that. Some of the basic predictors like ALK-FOX, gamma GT, if it can help you. LBI score, is coming in a big way, so I think if it can help you. Crafty score, which is a combination of CRP and AFP, if it can help you. And finally, the tumor stiffness based on, elastography, if it can help you. These are very clinical predictors which you can apply in your day-to-day clinical practice. I mean, these are not the preclinical setting, as I said, the tumor burden and all those